Hello, class. Hello.
Hello, Doc.
Yeah, can you all hear me?
Yes, please.
Okay, thank you very much.
Hello.
You are welcome to this class. I hope you can actually continue to hear me. Hello. Abdulatif.
Hi, Doc.
Yeah, I need all of you silent, but I need at least one person to unmute himself so that, or maybe Latif or any one person, so that I can get a response to know that I'm not talking to ghosts.
Hello, Doc.
Yeah, hello, Latif.
Yes, I can hear you.
You can hear me, okay.
I think
so
I'm
going to start the class.
Yeah, Doc.
Yeah, thank you very much.
Yes, we can start.
Okay, so basically I gathered that the difficulties where people had included liver function test, renal function test, and then some amount of acid-base balance, and then some amount of hormones. So I'll try and focus my areas from the data that was collected about your areas of weakness and interest in the revision. These are the areas I gathered. Liver function test, renal function test, and then acid-base balance, some lipid hormones together. So I'm going to, as much as possible, focus on the very important areas for the 2 hours we are going to have this lecture. Okay. So largely, I will not go on a detailed talking about the issue. I'll just focus on the very important areas. Firstly, what you see on the slide is telling you what the liver does. It also has implications for the pathology and clinical evaluation and diagnostic evaluation of a patient. Firstly, it is the site for the synthesis of lipoproteins, VLDL and HDL. It's also the site for the synthesis of bile acids. It is the site for the synthesis of hormones like insulin-like growth factor, angiotensinogen, and erythropoietin. The interest here is the erythropoietin. Okay, it's also the site for the detoxification of drugs, biotransformation, as we call it, and then the site for the storage of glycogen, fat-soluble vitamins, and vitamin B12. Good. What is the implication of these functions on the liver? Firstly, because the liver is the site for the synthesis of primary bile acids, if the liver is not functioning well, you will not be able to produce enough bile. If you don't produce enough bile, the bile will not be stored in the gallbladder. The intestines to help you to emulsify fat. So you are able to break down all the fat in your food that you have eaten into small droplets called micelles. Then you can absorb it. So if your liver is diseased and your liver cannot send bile to the intestine, it simply means that you will have a deficiency in the digestion and absorption of fat. If you cannot digest and absorb fat, then the fat will stay in your stomach for so long because there's no bile acids coming from the gallbladder because the liver hasn't produced the bile. Then what will happen is that when the fat stays in your intestines for too long, bacteria begins to act on the fat. And so you will develop a diarrhea. That diarrhea, when it comes out, it is called steatorrhea because it is full of fat. So steatorrhea is fatty diarrhea. That's one of the implications for the fact that it is a site for the synthesis of the bile acids. Also, the fact that it is the site for the synthesis of erythropoietin means that most people who have liver diseases will begin to have anemia and other red cell deficiencies, because you need erythropoietin coming from the liver, stored in the kidney, and secreted to the bone marrow to allow you to produce adequate red cells. So people with liver diseases are likely to have anemia. This is the explanation. Simply means that erythropoietin production has been decreased because the liver is diseased. Good. And people who also have liver diseases have a problem actually metabolizing drugs. So they have what we call drug intolerance and drug toxicity, because the liver is the main site for the detoxification of drugs. And so if the liver is not diseased, when you take any drug, you are unable to metabolize it or to detoxify it. And so the same food that you eat in a healthy situation that allows you to be able to detoxify it and feel free, now you take the same food and the food is becoming a bit more toxic to your body because your liver cannot detoxify it. You cannot biotransform it. It is because the liver is where detoxification happens. The liver is also the site for the storage of glycogen, fat-soluble vitamins, and vitamin B12. The important word here is glycogen and fat-soluble vitamins, because if the liver is diseased, when you eat food containing excess glucose, you store the excess glucose as glycogen. Now your liver is diseased. Muscles also store glycogen, but the liver is the major storer of glycogen. So if the liver is diseased, you have a deficit of glycogen storage. So it affects your energy levels. So people with liver disease, you see them very frail and weak in energy because they don't have adequate glycogen reserves because the liver is diseased. Good. Then the fat-soluble vitamins, what is the implication? Because the liver is the site for storage of fat-soluble vitamins, liver is diseased. It's simply that the availability of these vitamins is compromised. This is compounded by the fact that even when you eat food with adequate vitamins in there, it is the key word here is fat soluble. Fat soluble vitamins like vitamin K and other vitamins, they are fat soluble. So if the body has to absorb them, they are absorbed together with fat. They are absorbed complex with fat. So if you have a liver disease and the liver is not sending bile to the gallbladder, it's not forming bile to be stored in the gallbladder, in that case, bile is not being sent to your intestines. It simply means, as I said earlier on, you cannot absorb fat. Once you cannot absorb fat because the bile doesn't break down the fat into smaller droplets called micelles for you to absorb. Once you cannot absorb the fat, then also, consequently, you cannot also absorb fat-soluble vitamins. So even if there is adequate vitamins in your diet, you'll be deficient of the fat-soluble vitamins. So these are the pathological consequences of the functions of the liver when they are deranged. So I've tried as much as possible to summarize them for you. Then let's go a bit higher. We all know that there's prehepatic disease, there's hepatic disease, and there is post-hepatic disease. When we say prehepatic disease, you all know that we are talking about hemolysis, G6PD, malaria, things that happen before we get to the liver, in the bloodstream, intravascular hemolysis. When we talk about hepatic disease, we are talking about hepatotoxic drugs, bacteria, parasite, Fasciola hepatica, other parasites like malaria parasite that affect the liver directly, causing what we call injury to the liver cells. That is hepatic injury. And then we have post-hepatic injury, which has to do with the gallbladder, the bile duct, after we have left the liver. What is the implications of what I'm saying? The implications of what I'm saying will be seen in this diagram. This particular diagram, you can see that we have the blood vessel on top. What is this vessel? This is the blood vessel. Here, extravascular hemolysis and intravascular hemolysis have brought red blood cells into the blood vessel. When we leave the blood vessel, so anything that happens in the blood vessel, we call it as prehepatic, malaria, G6PD, whatever it is. Then when we leave the liver, if there's injury to the liver cells, we call it as hepatic disease. And if we leave the liver and we are in the gallbladder and the intestines, we actually call it as post-hepatic. So let's see the pathology that can happen. What is the diagnostic consequences of prehepatic, hepatic, and post-hepatic jaundice? Firstly, if you have prehepatic jaundice and hemolysis, whether intravascular or extravascular, is happening, you are likely to produce an increased amount of unconjugated bilirubin. And so prehepatic jaundice is characterized by unconjugated hyperbilirubinemia. That is increase in unconjugated bilirubin. So to use bilirubin to diagnose prehepatic, call an increase in the unconjugated bilirubin, but then the total bilirubin should also increase, because total bilirubin will be conjugated bilirubin plus unconjugated bilirubin. So once one of the components of the total bilirubin increases, then the total bilirubin also increases. Unconjugated bilirubin increases, total bilirubin increases. What other pathology, diagnostic pathologies do we see? Because hemolysis is here. Whenever hemolysis is going on for a long time, the accumulation of large amounts of unconjugated bilirubin results in increased amounts of conjugated bilirubin and increased amount of bile. So you can see in this diagram, the more bile we have, the more bile is sent to the intestines, the more some of the bile becomes urobilinogen. The more the urobilinogen can pass through the hepatic portal vein and get to the liver. The urobilinogen can also leave the hepatic portal vein and get to the blood vessel. In roaming the blood vessel, it will get to the kidney. When it gets to the kidney, it is excreted as urinary urobilinogen. So anybody that has increased hemolysis, intravascular or extravascular, will have increased urobilinogen. And so if you have malaria, you have sickle cell anemia, you have thalassemias, any disease that compromises red cell integrity, for which red cells are lyse faster than normal, you will have an increase in urinary urobilinogen. So when you do your microscopy and you see a malaria parasite, one of the chemicals you should look for in your urine is urobilinogen, because malaria will give you increased hemolysis. G6PD will cause increased hemolysis. Thalassemias will cause increased hemolysis. Sickle cell disease will cause increased hemolysis. All of them will add on to the urobilinogen load. So your urobilinogen levels will begin to increase in these conditions. So in prehepatic disease, the jaundice that we see is characterized by increase in unconjugated bilirubin, and then it is characterized by increase in total bilirubin. We will also see urobilinogen in the urine. The urine of patients who have prehepatic jaundice is actually increased in urobilinogen. Good. But then this is the cliche. What you should also know is that when the unconjugated bilirubin is formed, okay, the red cells, when they are lysed, the red cells contain hemoglobin. So the hemoglobin is split into heme and globin. A molecule called haptoglobin is bound to the hemoglobin to prevent the hemoglobin from being lost. That is an evolutionary strategy to conserve hemoglobin. So our body doesn't like to lose the hemoglobin in the kidney as urinary hemoglobin. So immediately malaria, G6PD, sickle cell disease causes a lyse of the red blood cells, haptoglobin immediately binds to the heme, so that the heme haptoglobin complex has a larger molecular weight. So when it reaches the kidney, it cannot pass through the pore size of the kidney's ultrafiltration. So it is conserved. But in the same breath, all the haptoglobin, once hemolysis continues to increase, the haptoglobins are used to bind to the heme. So free haptoglobin levels decreases. It is one of the diagnostic markers of prehepatic jaundice. In prehepatic jaundice, you have increase in unconjugated bilirubin, increase in total bilirubin, and a reduction in the amount of free haptoglobin. That is the cliche you should have. Then we have also now said that in prehepatic jaundice, there is increase in urobilinogen. What about the feces? So we have now use urine to differentiate prehepatic jaundice. What about feces? The feces of people with prehepatic jaundice will be very dark. Why? It is the bilirubin or the bile that comes from the gallbladder that goes to the intestines that breaks down into mesobilinogen stechobiology, and colors your feces as golden brown. So the more red cells are lysed, the more sickle cell makes your red cells to be lysed, the more malaria makes your red cells to be lysed, the more GCPD makes your red cells to be lysed, the more unconjugated bilirubin you produce, the more bile you produce, the more conjugated bilirubin and bile are sent to your intestines. Once that happens, it simply means that you will also produce an increased amount of urobiology. I really hope I'm making sense here. So we are simply saying that more hemolysis, more unconjugated bilirubin, more conjugated bilirubin, more bile, then more mesobilinogen, more stechobilinogen, the more urobilinogen. But the most important point I'm making is that because more bile is entering your intestine, your feces will become dark in color. How different is it? So if you remember here, we have established some two differences. We said that if you have a liver disease and your liver is not sending bile to your intestine, you develop steatorrhea. That is what we call post-hepatic. Because you are not able to send bile to your intestine, it means the gallbladder area, this area, that bile should lead to and get to the intestine is not there. Because you are not sending bile to the intestine, it simply means that you develop what we call steatorrhea, fatty diarrhea, and that happens in people with post-hepatic jaundice. But that doesn't happen in people with pre-hepatic jaundice. Because in pre-hepatic jaundice, you have adequate amount of bile produced. So that bile gets to the intestine and breaks down the fat into small micelles, and you are able to absorb them. So it does not accumulate and cause irritation of the colon, causing steatorrhea or fatty diarrhea. So we have now been able to, we are going to further on use feces to differentiate pre-hepatic, hepatic, and post-hepatic. We have now established that the feces of people who have pre-hepatic is dark because of increasing bile. But that is because more red cells are broken down, and so more bile is produced. But if you have hepatic jaundice, if the jaundice is coming from a disease of the liver, fasciola hepatica, hepatitis B, hepatitis C, any of the viral hepatitis, once that begins to affect the liver, what then happens is that you do not produce increasing amount of bile. So your feces, because normal amount of bile goes to the intestines, your feces will look what we call normal brown color. Your feces will not be dark. It is the intensity of the mesobilinogen and the stechobilinogen that gives pre-hepatic people a very dark feces. But if you are a hepatic jaundice patient, because you are not producing so much unconjugated bilirubin, your conjugated bilirubin levels are normal, your bile is also normal. So when you send it into the intestine, the concentration of the mesobilinogen and the stechobilinogen is not so much. So your feces remain golden brown or brown colored. What about somebody with post-hepatic jaundice? We have just established that somebody with post-hepatic jaundice, he is not the gallbladder and the bile duct. That's when we have left the liver. The bile should go to the gallbladder and get to the intestine. There's a blockage of the gallbladder, inflammation of the gallbladder that is blocking the bile duct. So bile is not going to the intestine. That is why you are developing the steatorrhea. Inherent in that process, you agree with me that because bile is not going to your intestine, it simply means that mesobilinogen, stechobilinogen, which are breakdown products of deconjugated products from conjugated bilirubin, because they are not present, they cannot be sent from your gallbladder to the intestine, then there's no pigment to color your feces. So your feces now stays as clay or pale colored. Your feces stay pale or clay colored. That is the difference between the feces of somebody with pre-hepatic jaundice, somebody with hepatic jaundice, and somebody with post-hepatic jaundice. The person with pre-hepatic jaundice will actually have a dark feces. The person with hepatic jaundice will have a brown feces. Then the person with post-hepatic jaundice will have a clay-colored feces. We have also established here that the person with pre-hepatic jaundice will have increasing urobilinogens in their blood and as well as in their urine. unlike somebody with hepatic and post-hepatic jaundice. Let's now come to hepatic and post-hepatic jaundice and differentiate them in terms of urobilinogen and bilirubin. Mind you, immediately you produce unconjugated bilirubin. Remember, unconjugated bilirubin binds to albumin. And so the size of unconjugated bilirubin and albumin complex has an increased molecular weight. So anytime unconjugated bilirubin is available in the blood, it doesn't appear in the urine. The reason is that immediately unconjugated bilirubin is produced, albumin binds to it, creates a larger molecular weight. So you don't find unconjugated bilirubin in your urine because it cannot pass through the pore size. So anytime you have prehepatic jaundice and the jaundice is characterized by unconjugated hyperbilirubinemia, you don't expect to see bilirubin in your urine because that unconjugated bilirubin is largely bound to albumin. But you see, if you now have hepatic jaundice, which is characterized by both conjugated and unconjugated hyperbilirubinemia, because some amount of unconjugated bilirubin is there, we will have assumed that, oh, we won't find bilirubin in the urine. No, but there is also conjugated bilirubin. And conjugated bilirubin is already soluble in the aqueous medium of the blood. So it doesn't require to be bound to albumin transported in the blood. So albumin does not bind to conjugated bilirubin because the binding of albumin to unconjugated bilirubin is to make unconjugated bilirubin soluble in the aqueous medium of the glucuronic acid to the conjugated bilirubin. That's why we call it conjugated bilirubin. Glucuronic acid makes them soluble in water. So they don't need albumin to dissolve in blood. By virtue of that, their molecular weight is also small. Albumin should have bounded to give them a larger molecular weight so that they will not appear in urine. But because they are already soluble, they don't need albumin. So their molecular weight is small. So anytime you get increases in conjugated bilirubin, expect to see bilirubin in your urine. So for people who have hepatic jaundice and post-hepatic jaundice characterized by increases in conjugated bilirubin, see bilirubin in their urine because the size of bilirubin not bound to albumin makes the molecular weight small, so it can always appear in urine. So that's the differential. So in prehepatic jaundice, we will say that we will not see bilirubin in the urine, but in hepatic jaundice and post-hepatic jaundice, we will see bilirubin in the urine because that is characterized by a significant amount of conjugated bilirubin. We all know already, I'm sure from your lectures in school, you all already know that prehepatic jaundice is characterized by unconjugated bilirubin. Then hepatic jaundice is characterized by both conjugated and unconjugated hyperbilirubin increase. Then post-hepatic jaundice is characterized by an increase in conjugated bilirubin alone. So in both hepatic jaundice and post-hepatic jaundice, we have a significant amount of conjugated bilirubin, which means that because the molecular weight is small, it circulates in the blood and we will find it in the urine. So in the laboratory, if you are asked, in which of the conditions will you see bilirubin in the urine? You straightforward know that it is in hepatic jaundice and post-hepatic jaundice. In prehepatic jaundice, you won't see bilirubin in your urine because all that bilirubin has been bound by albumin to conserve it and make it soluble. So you see, in this lecture, we have differentiated for you the pathologies of prehepatic, hepatic, and post-hepatic jaundice using urine, urobilinogen, and bilirubin. We have now also used two. I've done these two differentials for you. Good. Now let's go to the blood. This is something I shouldn't have said because I expected that you shouldn't forget this. But let's just recap it. In the blood, what are the things you see? In prehepatic jaundice, you see unconjugated hyperbilirubinemia. You won't see increase in alkaline phosphatase. You might see some moderate increase in AST because some amount of AST is found in red blood cells. So as malaria, GCPD, and sickle cell is lysing your red cells, you expect to see moderate amount of increase in AST. But you won't see an increase in ALT. You won't see an increase in alkaline phosphatase. But you see an increase in conjugated bilirubin. Oh, sorry, unconjugated bilirubin. That will result in an increase in total bilirubin. Good. Then you come to hepatic. In hepatic jaundice, characterized by liver disease, you will see both conjugated and unconjugated hyperbilirubinemia. You won't see alkaline phosphatase, but you will see a marked increase in AST and ALT, because the two enzymes, aspartate aminotransferase or gamma oxalotransferase, and alanine aminotransferase or gamma pyruvic oxalotransferase are rich in the liver. So anytime the liver is diseased, AST and ALT increases markedly. Remember, I said in the pre-hepatic jaundice, moderate increase. But in hepatic jaundice, you have a marked increase in AST and ALT, but no increase in alkaline phosphatase. Then you come to post-hepatic. In post-hepatic jaundice, it is characterized by an increase in conjugated bilirubin. But apart from the increase in conjugated bilirubin, you also have an increase in alkaline phosphatase. So it is only in post-hepatic jaundice that alkaline phosphatase increases in terms of liver specificity. So in post-hepatic jaundice, you see increase in conjugated bilirubin, normal unconjugated bilirubin levels, and an increase in total bilirubin. Good. But then you also see an increase in AST. It stands to reason that you will have said that, oh, then it means in post-hepatic jaundice, we don't see increase in AST and ALT. No, that's not true. In post-hepatic jaundice, when it stays chronic and lasts for a long while, we begin to see an increase in AST and ALT. Why? Because in post-hepatic jaundice, it is the prevention or there's a blockade of bile getting to the intestine. So the bile piles up. Eventually, when the bile piles up in the gallbladder, it finds its way into the blood. And then when it gets to the liver, it becomes toxic to the liver cells. So as accumulation of bile begins to injure liver hepatocytes, the liver injured cells begin to release some amount of AST and ALT. But that is not marked increase. That is moderate increase. That increase might be about 2 times compared to the hepatic injury. In post-hepatic injury, you will find AST and ALT increasing, but probably about 1 times or 2 times. But when we are talking about hepatic disease, the AST and ALT increases about 3 times above the upper limit of normal. So there's a difference in there. Good. So I have just told you that in post-hepatic disease, you have increase in conjugated bilirubin, increase in alkaline phosphatase, okay? And now I have also added that once that happens, it eventually in chronic situations can lead to an increase in AST and ALT in moderate amounts, but not as marked as in the hepatic disease. I hope I have been able to break down for you the various differential pathologies in pre-hepatic jaundice, hepatic jaundice, and in post-hepatic jaundice. Good. Then I will go to the next class. Can you hear me?
Yes, please.
Yes, please.
Is my lecture very clear?
Yes, loud and clear and exciting.
Thank you very much. Thank you very much. Thank you, man. Is there anything I should change in my lecture? Do you have any advice? Are we all on the same page?
Yes.
I'll take
Doc,
suggestions.
please, there's a question.
A question. Wouldn't you write it down when the lecture, then you ask the question?
Okay, so when we are done, I think
So
you can look at the
don't
chat.
confuse the lecture, because these are bulletin lectures.
Okay.
So write your lecture, write your question down.
So Doc, anyone who has a question should put it in the chat. Once you are done, you can review and then answer them.
I can go to the chat and review it and
Yes,
answer them.
when you are done, yes.
Just state your name and your question so that I can address you as a person.
Yes, once they send the chat, their names will appear.
Will come automatically. Thank you very much.
Automatically, okay.
Thank you very much. So let me move to another area which I think might be confusing for you in the liver function test. It has to do with the jaundice, icterus jaundice in adults and children. Okay, jaundice is simply the coloration, yellowish coloration of the tissues of the skin because bilirubin is being piled up. Okay, most of the time, doctors who work with children for a lot of the time, they can pick up bilirubin even when the concentration in the blood is just about 35 micromole per liter. But most clinicians will only see jaundice overtly when bilirubin levels are about 70 micromole per liter. Jaundice is not a diagnosis. It is only an underlying disease. So when you see jaundice, or when a clinician sees jaundice as a symptom, he has to go and find out what the pathology is. He will conclude by saying it is pre-hepatic jaundice, hepatocellular jaundice, or post-hepatic jaundice. Let's break it down. I've already told you what pre-hepatic is. Okay. So what post-hepatic is? You have seen that this is These are examples of post-hepatic. These are not things I need to explain. You just have to go and read and you will follow. Good. So let's look at the laboratory differentials. Here, you see that the hemolytic is what we call the pre-hepatic. This is hemolytic. That's what we call the pre-hepatic. Then the hepatocellular is what we call the hepatic here. Then this one, we call it post-hepatic. We also call it cholestatic jaundice. I've classified for you all the levels. Let's find out why in hemolytic disease or pre-hepatic jaundice, why all these parameters change. In hemolytic jaundice or pre-hepatic jaundice, we have already said that you will find bilirubin levels less than 75 micromole per liter. Okay, but which of the bilirubins are increasing in pre-hepatic? The one that is going to increase is actually unconjugated bilirubin. Here, we will not see bilirubin in the urine. No bilirubin in urine. Why? Why is there no bilirubin in urine? Because that bilirubin is unconjugated bilirubin. It has been attached to albumin. The molecular weight is big, so it cannot appear in urine. It cannot pass through the pores of the kidney. Then there is reticulocytosis. Why? Why is there reticulocytosis? It is a response to the decreasing and the increasing distraction of red blood cells. Anytime you get anemia, the bone marrow is triggered to respond to erythropoietin, and you now begin to produce immature red cells. In an attempt to compensate for the anemia and the decreased red cells, your body then now goes into what we call a push of immature red cells into circulation. And immature red cells are called reticulocytes. So you develop reticulocytosis. Then hemoglobin level is decreased because once your red cells are being broken down, obviously your hemoglobin will decrease. So you can see it here. Hemoglobin is decreased. Then haptoglobin is also decreased. Why? Because I told you that anytime heme is being formed from red cell breakdown, haptoglobin binds to hemoglobin to conserve heme. So haptoglobin levels will decrease. Lactate dehydrogenase will increase. Why? Some amount of lactate dehydrogenase, LDH1, is found in red cells. And so lactate dehydrogenase increases. Let's go to the hepatic jaundice. In hepatic jaundice, we will see bilirubin increasing later. Which of the bilirubins? Both conjugated and unconjugated bilirubin. Because when the liver cells is injured, some of them have finished their conjugation. They will die and release their content. So they will release conjugated bilirubin. Some have just released the unconjugated, they have just received it from the blood or albumin. They haven't begun the conjugation. But hepatitis B is killing them. So they release their content. They will release unconjugated bilirubin. So in hepatic disease, both conjugated bilirubin and unconjugated bilirubin increases in concentration. So it is characterized by both conjugated and unconjugated hyperbilirubinemia. We have also said that AST and ALT are found in the liver. So you will see a marked increase in AST and ALT. So you've seen that I have given it double increase in AST and ALT. Good. Then in terms of bilirubin, we said that it is we call it biphasic hyperbilirubinemia. Both phases, conjugated and unconjugated, have increased. So we call that type of increase in bilirubin as biphasic because we have both conjugated and unconjugated hyperbilirubinemia. Then I've said that in hepatocellular jaundice, alkaline phosphatase will not increase. It is when the disease becomes so chronic that you might find some modest increase in alkaline phosphatase. Even that one is modest, very mild. But in cholestatic jaundice, which is hepatocellular, which is post-hepatic jaundice, bilirubin will increase. What type of bilirubin here? Cholestatic jaundice is post-hepatic jaundice. So if we see cholestatic jaundice, what type of bilirubin will increase? Conjugated bilirubin. But will we find a bilirubin in urine? Yes. Why? Because conjugated bilirubin is not bound to albumin, so the molecular weight is small. So we will see bilirubin in the urine. You see the same way in hepatocellular jaundice, we are seeing bilirubin in the urine because that bilirubin is conjugated bilirubin, so it's not bound to albumin. So its molecular weight is small. So we'll find that bilirubin in urine. But in pre-hepatic jaundice, we say there is no bilirubin in urine because that bilirubin is unconjugated bilirubin. It is bound to albumin, so cannot be sieved in the kidney into urine. Good. Then we now come to alkaline phosphatase. Because alkaline phosphatase is chiefly found in the bile duct, the biliary tree, you will find that alkaline phosphatase increase about 3 times the upper limit of normal in post-hepatic jaundice. I've said that ideally you will have said AST and ALT will not increase. No. Yes, in the early days, AST and ALT will not increase. But as the bilirubins pile up in concentration in your blood, eventually they get to the liver and they begin to injure some of the liver cells. So the liver cells begins to increase AST and ALT modestly. Lactate dehydrogenase type 2 or 3 is found in the liver. So the lactate dehydrogenase also begins to increase slightly. But the increase in AST and ALT is usually modestly increased. So you just probably see, I've given it just one arrow up there. But when we come to hepatocellular, I've given it 2 or 3 arrows. Beautiful. So you can see the differentials. My cousin will say, if you don't understand this, I don't know where you'll be taught for you to understand again. It is a proper breakdown of the differential diagnosis. So let's go to another, the inherited hyperbilirubinemia. I think it's a difficulty of a lot of people. Crigler-Najjar syndrome, Durbin-Johnson syndrome, Rotor syndrome, Gilbert syndrome. What is it? What is it? What are the pathologies? The pathologies are simple. You see, we have just said that when you form bilirubin, it goes to the gallbladder to be stored, and then it goes to the intestines to allow you to absorb fat. Yeah, there's something I needed to talk about in the, let's go back. I should have spoken about it. It's very important. So let's go back. Here, let's go back. Good. In the post-hepatic jaundice, we have said that once it is post-hepatic, you are not able to send bile into the intestine, so you can't absorb fat. If you can't absorb fat, it means all fat-soluble vitamins that you eat, they will go out as feces. So somebody with post-hepatic jaundice, we have said his feces is pale colored or clay colored. We said he will get steatorrhea, fatty diarrhea. What other things can we say about such a patient? For all the 3 categories of patients, pre-hepatic, hepatic, and post-hepatic, which of them, if any of them gets a disease of red blood cell coagulopathy, and we need to give them vitamin K to correct the coagulopathy, which of these people can you give oral vitamin K2 or parenteral vitamin K2? Oral is from the mouth, parenteral is direct injection into the blood vessel. So we are simply saying that if somebody suffers from post-hepatic jaundice and he cannot absorb a lot of the fat-soluble vitamins, if you need to give him vitamin K to correct a blood hemoglobinopathy or blood pathology or a bleeding disorder, a clotting disorder, you cannot give him oral vitamin K. Because if you give him oral vitamin K for him to swallow, it will go to the intestine. Still, he cannot absorb the oral vitamin K. So if you need to correct his coagulopathy with vitamin K, you have to by all means give him a parenteral injection of the vitamin K. But for somebody with pre-hepatic and hepatic jaundice, because he doesn't have a problem with breaking down fats and absorbing them, if he has a problem with a coagulopathy and you have to give him vitamin K, you can give him oral tablets, because when he takes the oral tablets, his intestines will be able to absorb it. So Dr. Ali is back. Abdulatif.
Yes, Doc.
Hello, Latif.
Yeah, Doc.
Yeah. Can you see my, am I sharing my slide? Can you see
it? No.
Let me share again.
No.
Let me share again. You can see now?
Yes.
Good. So, please, for the Doctor of Medical Science people, hello, I've given a general lecture to both diploma and degree students. For the Doctor of Medical Science people, you need to understand this very, very well in terms of the fine differentials and the implications for treatment. Okay, you need to understand it very well. One patient cannot absorb vitamin K and fat-soluble vitamins because he's not able to send bile to the intestine because he has post-hepatic jaundice. And we are saying that for people with post-hepatic jaundice, because they cannot absorb the fat-soluble vitamins, example, vitamin K, if they have any coagulopathy or bleeding disorder, and you need to correct it by supplementing or giving them vitamin K, you cannot give them oral vitamin K because they cannot absorb it in their intestines because they don't have bile to help them in absorbing the vitamin K. So for such people, you can only give them parenteral injection of vitamin K to correct their coagulopathy. Whilst for the prehepatic and the hepatic patients, any patient suffering from prehepatic and hepatic jaundice, if the patient needs to be given vitamin K to treat a coagulopathy, you can give that patient oral vitamin K because he doesn't have a problem with digesting and absorbing the fat-soluble vitamin K as part of micelles to be absorbed. So if I ask you for prehepatic, hepatic, and post-hepatic patients, which of them will benefit from oral vitamin K therapy? You should be able to differentiate. The only people who will benefit is prehepatic and hepatic patients. They will benefit from oral vitamin K supplement. But the post-hepatic person will only benefit from a parenteral injection. Thank you very much. I needed to make this clear.
It's clear.
You see?
I said it's clear.
Good. So I'm going to the congenital hyperbilirubinemia. Gilbert syndrome. If you still remember your lecture of liver function when you were in school, when there is what we call a reduction in the lifespan of the red blood cell, erythrocytes are lyzed faster than normal. And so in Gilbert syndrome, there is what we call a destruction of the red blood cells. The real pathology in Gilbert syndrome is that anytime you produce unconjugated bilirubin in the blood vessel, you need ligandins X and Y and Z. They are the receptors to allow for unconjugated bilirubin to attach to the ligandins on the hepatocyte in order for the unconjugated bilirubin to be endocytosed into the hepatocyte before you can conjugate it with glucuronic acids. But in such patients, their disease is characterized by a defective uptake of the bilirubin by the hepatocyte. It simply means that their X and Z ligandins and the receptors for the unconjugated bilirubin albumin complex are deficient. So they create a backlog of unconjugated bilirubin. Their body is characterized by huge levels of unconjugated hyperbilirubinemia. Their serum bilirubin can go up to 40 micromole per liter because they are unable to uptake unconjugated bilirubin. Good.
Doc, please, can you come again?
Okay, so let me come again. I'm sure we all know that when intravascular hemolysis or extravascular hemolysis happens in the blood vessel, albumin comes and binds to the unconjugated bilirubin created, and albumin transports the unconjugated bilirubin to the liver. Then there are receptors on the liver called X and Z ligandins, which allow for the unconjugated bilirubin albumin complex to attach to those ligandins. They serve as receptors to allow for the unconjugated bilirubin albumin complex to be endocytosed into the interior of the hepatocyte. Then the albumin returns back to the surface and is released to go and bring more unconjugated bilirubin. So what then happens is that if the X and Z ligands, the receptors, which should allow the albumin unconjugated bilirubin that has been brought by the blood vessel to the liver to be uptake and received, if the receptors are deficient, then you cannot put unconjugated bilirubin into the hepatocyte. So there's a backlog, an excess unconjugated bilirubin piling up in the blood vessel, causing unconjugated hyperbilirubinemia. That is the disease Gilbert syndrome. I hope it's clear.
Yes, please.
Good. So the serum bilirubin, characterized by increasing unconjugated bilirubin, can rise during intercurrent illnesses and even when they are fasting. Gilbert syndrome can present at any age, but more commonly we see it in the second decade of life, from the 20 years going. That's when we see Gilbert syndrome. Crigler-Najjar syndrome. What is Crigler-Najjar syndrome? We all know that after the X and Y ligands have allowed for the albumin to offload the unconjugated bilirubin into the hepatocyte, we add 2 molecules of glucuronic acid. First, we add 1 molecule of glucuronic acid to form bilirubin monoglucuronide. Then we add another molecule of glucuronic acid to form bilirubin diglucuronide. It is this bilirubin diglucuronide that we call as conjugated bilirubin. The enzymes that add the first and the second glucuronic acid are called UDP glucuronide transferase 1 and 2. For patients that suffer from Crigler-Najjar syndrome, they have a deficiency of the glucuronide transferase 1 and 2. So even if you put unconjugated bilirubin in their liver, they cannot conjugate it. There are 2 categories. We have type 1 and type 2. The type 1 patient of Crigler-Najjar syndrome, it is characterized by they have a marked deficiency of the enzyme. So they don't have any of the enzyme at all. Because they don't have any of the enzyme at all, that is huge deficiency in the enzyme. So anytime they have that disease, they accumulate large amount of unconjugated bilirubin. And unconjugated bilirubin is dangerous. That's why Crigler-Najjar syndrome is one of the most dangerous diseases of the conjugated or of the genetic hyperbilirubinemias. This is the reason why unconjugated bilirubin, because it is derived from the protoporphyrin ring of heme, is still a lipid. It's still a lipid. But conjugated bilirubin is not a lipid because we have added 2 molecules of glucuronic acid to it. So it is now polar. But the unconjugated bilirubin is still non-polar. So because the phospholipid layer of all cells in the body is largely made up of phospholipids, any substance that is a lipid can easily cross the phospholipid layer, and that is unconjugated bilirubin. Because unconjugated bilirubin is still a lipid, it is easily allowed to cross the blood-brain barrier into cells. So if a child has so much unconjugated bilirubin in his blood, the unconjugated bilirubin can easily cross his blood-brain barrier, diffusing across the phospholipid layer, entering into the brain, and pigmenting the brain, destroying it in a disease called kernicterus. And the child will now have low IQ, low intelligence, and low coordination of his neurons. So in Crigler-Najjar syndrome, so take it from this lecture, unconjugated bilirubin is more dangerous in causing kernicterus than conjugated bilirubin, because conjugated bilirubin is polar and it is not easily allowed to cross the phospholipid layer. But unconjugated bilirubin is still a lipid and so can easily cross the cell membrane, cause kernicterus. So if you're asking in exams, which of the bilirubins can cause kernicterus more? It is unconjugated bilirubin because it is still a lipid. And because the cell membrane is a phospholipid, it allows its colleagues that are lipids to cross. Whilst the conjugated bilirubin has been conjugated with 2 molecules of glucuronic acid, so we call it as a polar substance. Polar substances are not easily allowed to cross the cell membrane. Type 1, I have said, is characterized by a marked deficiency of the enzyme. So because the enzyme is totally deficient, unconjugated bilirubin accumulates so much that it can easily cause kernicterus in infants, destroy their brains, and damage their life. Kernicterus is the abnormal accumulation of pigment in the brain. Type 1 is marked deficiency, but type 2 is partial deficiency of the UDP glucuronidtransferase 1 and 2 enzymes. If you don't have the UDP glucuronidtransferase 1 and 2 enzymes, they are there in partial amount. You only have small. It means you can do some conjugation, but you can't do enough conjugation. So only a moderate amount of unconjugated bilirubin pass up. The serum bilirubin may be reduced or may reach about 50 micromole per liter. It may be reduced by drugs such as phenobarbital, which induces the hepatic enzyme synthesis. So when a patient is given phenobarbital, it increases the amount of UDP glucuronidtransferase 1 and 2 he can produce, now offsetting the backlog of unconjugated bilirubin, and the patient is now able to deal with the unconjugated hyperbilirubinemia by conjugating it. So if you give him phenobarbital and it will increase the amount of UDP glucuronidtransferase enzymes, then it can solve the problem of kernicterus. Crigler-Najjar syndrome usually presents at birth. By the time you are born, you have Crigler-Najjar. That's what makes it dangerous. Remember, the Gilbert syndrome occurs in the second decade of life. By that time, it's maturing. So even if you get bilirubin pigments getting into your brain, it is not as deadly as the Crigler-Najjar syndrome, which happened at birth, because at birth is the reformative period of your brain cells. So if they are destroyed, then you are finished forever. So because Crigler-Najjar syndrome presents at birth, and it is characterized by the type 1, it's characterized by marked deficiency. The type 1 is dangerous in causing kernicteric jaundice and destroying the future of children. While the type 2 still causes some damage, but not as much as the type 1, because that one, the UDP glucuronidtransferase 1 and 2 are there in small amounts. So they are able to do some conjugation. And when we give you phenobarbital, it's able to induce a hepatic enzyme synthesis. So you can now get more amount of UDP glucuronidtransferase 1 and 2 to do the conjugation. So there's effect, no backlog of unconjugated bilirubin to cause kernicterus. Durbin-Johnson syndrome. But if you watch the two phases, the Gilbert syndrome and the Crigler-Najjar syndrome, which bilirubins did we accumulate? Unconjugated bilirubin. So we call them congenital unconjugated hyperbilirubinemias, because they are congenital, because lack of the enzymes, UDP glucuronidtransferase 1 and 2, and lack of the ligandin X and Z receptors are all genetic problems. You didn't inherit the gene to produce them. So we say they are congenital. We say they are congenital unconjugated hyperbilirubinemias because largely they produce unconjugated bilirubin, because it's about destroying of the red cells, lack of uptake of the unconjugated bilirubin, and incapacity to conjugate. So what passes up is largely unconjugated bilirubin. So we call them congenital unconjugated hyperbilirubinemias. Then we have the congenital conjugated hyperbilirubinemias. They are congenital because most of the causing pathologies are genetic. So we say congenital. But then they are conjugated hyperbilirubinemia because what accumulates is not unconjugated bilirubin. It is conjugated bilirubin. For example, Durbin-Johnson syndrome. What is Durbin-Johnson syndrome? It is characterized by the defective excretion of bilirubin, but not bile salt, into the biliary tree. So in Durbin-Johnson syndrome, we don't have a problem with uptake of unconjugated bilirubin. The X and Y ligandins are there, so we are able to uptake the unconjugated bilirubin. We don't have a problem with UDP glucuronidtransferase 1 and 2, so we are able to do the conjugation. It is after we have done the conjugation and we have produced the conjugated bilirubin, now we need to excrete it into the gallbladder, send it there, and then store it together with other bile salts as bile. But here, there is defective excretion of bilirubin, but not bile salt. So the bilirubins accumulate. So what accumulates is actually conjugated bilirubin. So in Durbin-Johnson syndrome, we say it is a congenital conjugated hyperbilirubinemia. It is associated with high levels of conjugated bilirubin. The affected subject presents with bilirubinuria. You already by now you know that when conjugated bilirubin is high, because it is not bound to albumin, it appears in the urine, and we call that as bilirubinuria. But the alkaline phosphatase is normal because it is not an infection of the bile duct or an inflammation of the gallbladder that is causing the disease. Most of the time, anytime we see bilirubinuria, we are likely to see increase in alkaline phosphatase. But this time around, that's not what happens. You will see bilirubinuria, but you won't see an increase in alkaline phosphatase because the bilirubinuria is caused by a genetic incapacity to actually excrete the bilirubin. But it doesn't affect the bile duct or the gallbladder. So alkaline phosphatase will not increase. Remember, in post-hepatic jaundice, you will see bilirubinuria. Bilirubin will appear in the urine. The same way alkaline phosphatase will increase. But in Durbin-Johnson syndrome, only urine bilirubin will be seen. We won't see increase in alkaline phosphatase. Thank you very much. The next one is called Rotor syndrome. Rotor syndrome is a congenital conjugated hyperbilirubinemia. Why? Because it is characterized by defective excretion of conjugated bilirubin. So we are finished forming the conjugated bilirubin. We are finished the conjugation, but we are not able to excrete it into the biliary tree. So conjugated bilirubin piles up. So you see, these people will also have bilirubinuria. The liver of this subject will have orange-yellow granules due to the accumulation of the pigment. Thank you very much. Let's talk about neonatal jaundice. What is the pathophysiology of neonatal jaundice? Jaundice that occur in children. What's the pathophysiology? Let's talk about it. In the first week of a neonate's life, there may be what we call physiological hyperbilirubinemia. Me and you, we are not getting hyperbilirubinemia because our liver has adequate amount of albumin to transport our unconjugated bilirubin to the liver. We also have adequate levels of the X and Y liganding receptors to allow for the endocytosis of the unconjugated bilirubin. We also have enough amount of UDP glucuronidase 1 and 2 to do the conjugation. So we will never get hyperbilirubinemia. But you see, in the first few weeks of a neonate's life, there is what we call physiological hyperbilirubinemia because, one, when you are born as a neonate, you have what we call an increased breakdown of fetal erythrocytes. When a child is born, the MCV of his red cells are big. He has a large MCV. The mean cell volume is larger. So it is easy for the spleen and the reticuloendothelial system to see large red cells as abnormal and begin to lyse them. So the child immediately undergoes hemolysis and he's increasing the amount of unconjugated bilirubin he's producing. Unfortunately, for that same child, his liver is not matured enough to have adequate amount of ligandins, UDP glucuronidase 1 and 2 to do the conjugation. He's now giving us a lot of unconjugated bilirubin. But we too should have had adequate amount of receptors, albumin to carry them, amount of the UDP glucuronidase 1 and 2 enzymes to finish the conjugation, backlog of unconjugated bilirubin in blood. Unfortunately, for these children, they have increased breakdown of their fetal red cells because the red cell mass in the neonate is high. So the spleen and the reticuloendothelial system sees it as abnormal. So it starts breaking down the red cells of these infants. Then, to make matters worse, their liver also has poor excretory capacity because there is low concentration binding protein X and Z, the receptors for the uptake of unconjugated bilirubin, and then the UDP glucuronidase 1 and 2, which will do the conjugation, are also low in activity and concentration. So it is like double trouble. So they get a backlog of unconjugated bilirubin, and you know they can easily develop. We call it physiological hyperbilirubinemia because if their liver was mature, no matter how much their red cells was seen as abnormal by the spleen, and the spleen was destroying them, their liver will have been capable of dealing with the excess unconjugated bilirubin. But here it is. They are now giving us more unconjugated bilirubin, but their liver is not even mature. So for such children, all they need is for us to buy time for them so that their liver will mature. Once their liver matures, they don't need our help again. They can deal with any excess hemolysis that is bringing unconjugated bilirubin. So we put such children in the what we call incubators with light, UV light. What do we So by the time their liver is mature, they have to be taken out of the incubator. They don't need help again, because no matter how much red cells is broken down, their liver is competent to deal with it. So in the villages, our parents learned long ago that if you give birth to a child with yellow eyes, you put him in the sun, because the UV light from the sun decomposes the bilirubins. And so it allows the child to have less brain damage. So there are two pathologies in neonatal jaundice. One, increased breakdown of fetal erythrocytes, because the erythrocyte mass in neonates is high. And so their red blood cells is easily seen as abnormal. So hemolysis happens intravascularly. Secondly, they have low hepatic excretory capacity, both because the ligandins X and Z, the receptors, are not matured to do the uptake, and then the enzymes UDP glucuronide transferase 1 and 2 are in low concentrations, so they cannot do addition of the glucuronic acid. What are the causes of neonatal jaundice? Hemolytic disease of the newborn, D6PD deficiency, blood group incompatibility, immaturity of the hepatic process, interference of hepatic transport functions by drugs. So sometimes a child can be born. He has adequate amount of the ligandin X and Y receptors. He has adequate amount of the enzymes, but because he has malnutrition, so his albumin levels are low. If your albumin levels are low, who will transport the unconjugated bilirubin to your liver for the glucuronation to be done? So malnutrition is very important. So when we are treating children with jaundice or neonatal jaundice, nutrition, adequate breastfeeding, and temperature is a requirement to treat such people. If you are even treating such a child and he's anemic and he also has what we call poor albumin in his blood, so he has malnutrition, the therapy will not work efficiently. So when children with neonatal jaundice are being treated, mothers are advised to give them adequate breastfeeding so that they can produce, their liver can produce enough albumin to transport the unconjugated bilirubin so that they do not develop icteric jaundice. Sorry, icteric or jaundice. Good. That is neonatal jaundice. The rest, I mean, you can read. There's nothing. This is also, there's nothing special about this. So I'll leave the rest of the lectures for you. I think everything is readable. What I've done is to break it down to what I believe to be the lowest level for you to follow. So now we will move to what we call the next difficulty that you have. And I presume the next difficulty will be acid-base balance. I will take acid-base balance. Class, are you okay?
Yes.
Hello, Doc.
Yeah, Adib.
Yeah, I wish you take the questions now before we move to acid-base.
Go. Thank you very much. I forgot it. Thank you. Thank you very much. Let me take the question. Let me go to the questions. I'm going to the chat. Please, is there the possibility where in the kidney failure, the unconjugated bilirubin albumin complex can pass through the pores and bilirubin appears in the urine? Yes, if you have nephrotic syndrome. In a normal person with a normal kidney, that will not happen. But if you have nephrotic syndrome or any type of inflammation, seriousness in inflammation increases the endothelial gap. Nephrotic syndrome, the sieving size of the bone mass capsule, the pore size has increased. So substances originally would not be allowed to pass through, now can pass through. So in nephrotic syndrome and diseases that have increased inflammation, you might then begin to see unconjugated bilirubin albumin complex as large molecular weight as it is appearing in urine. It's very possible. That's a brilliant question. Let's move to the next question. Doc, does GGT increase in cholestatic jaundice like ALP? Yes. Gamma glutamate transferase increases in post-hepatic jaundice, but gamma glutamate transferase is a marker of alcoholic hepatitis. So it also increases in hepatic disease, especially induced by alcoholic hepatitis. There's something we call the diuresis ratio. I don't know whether you have heard it. The diuresis ratio is AST over ALT. This is the cliche. ALT is believed to be a nuclear enzyme, and AST is believed to be a cytoplasmic enzyme. So alanine aminotransferase is believed to be in the nucleus, and aspartate aminotransferase is said to be in the cytoplasm. If a cell is being destroyed, the cytoplasm and the nucleus, which one will be destroyed first? The cytoplasm, of course. So it means that when a hepatocyte is being diseased, it will release AST before it's ALT. In the early stages of a liver disease, then it means that we will see more AST than ALT. If we see more ALT than AST, it means that the diuresis ratio, which is AST over ALT, will be greater than 1 because the numerator is bigger. But if the disease gets chronic, it's getting chronic, and more cells are destroyed, eventually a lot of nucleus will be destroyed. So a lot of ALT will be produced. When the ALT numbers begins to increase, ALT is the denominator. So when the ALT numbers begins to increase, then the ratio is getting less than 1. So we say when the diuresis ratio is less than 1, it indicates a chronic liver disease. And when the diuresis ratio is higher than 1, it indicates an acute liver disease. Go and read further about the diuresis ratio. Then we are come to GGT. GGT is an indicator of alcoholic liver disease. So GGT increases moderately in post-hepatic jaundice because some amount of GGT is found around the biliary tree. But largely, you will find increase in GGT in alcoholic hepatitis. Good. Should we be measuring what? Should we be measuring albumin as part of management of neonatal jaundice? Beautiful question, but no. This is the reason why we don't measure albumin as part of management of neonatal jaundice. Obviously, by the time we suspect neonatal jaundice, we ask you to go and do a liver function test. So albumin will be there, but we don't need albumin per se. The reason is that albumin levels can always be evaluated clinically. If you don't have enough albumin, you will develop edema. If you don't have enough albumin, your oncotic pressure is decreased, so you develop generalized edema. So that can clinically be seen. So the assumption largely in neonatal jaundice is that if the child had low levels of albumin, it will have reflected in the child developing edema. So we don't routinely want to be specific about albumin. Yes, if the clinician finds the liver function test because albumin is included, and he finds that the albumin levels are low, it probably means he didn't pick it up clinically in his evaluation. So consider albumin in diagnosis and treatment, because that simply tells him that if he's treating the child and the albumin levels is this low, then the recovery will be bad. So either the patient has to be given diet so that he can shore up his protein levels, or the mother is asked to breastfeed the child adequately so that the child can build up his albumin levels so that treatment can be supported and helpful. Thank you very much for that question. How can you detect unconjugated bilirubin albumin complex in urine in nephrotic syndrome? How? Of course, once the unconjugated bilirubin appears in the urine, you can use strips, urine strips to pick it up. That's very easy. You will see an increase in bilirubin. Of course, the urine strip doesn't tell you that this is unconjugated bilirubin, or it will tell you that this is bilirubin. But because you were suspecting it, because you were suspecting that in nephrotic syndrome, if once the nephrotic syndrome is confirmed, obviously once you see increase in bilirubin in the strip, you know that it's unconjugated bilirubin. Under what conditions will you have ALT higher than AST? I think I've just explained that. You have ALT higher than AST when the condition, the liver disease, is increasingly becoming chronic. The more chronic, the more ALT is becoming higher. Because we are now eating into the nucleus of cells. Thank you very much. It looks like there are no further questions. Unless I'm lying, but I can't see more further questions. So I think I'll consider LFT treated. Ablatif, unless there are any issues, I'll consider LFT treated.
Okay, that's fine. I think we've done justice to the topic. The rest is left for them to read around.
That is it.
Because we can't do everything.
No, it's not possible.
It's not possible. The main areas you've touched on, the rest is left for them to
Good.
Okay.
When are we expected to close? At 5, at 6 o'clock?
At 6, yes.
Okay. Right.
So we have less than an hour to go.
An hour, okay. All right. So let me take acid-base balance. Because that's the first thing that I saw. Okay, it's one of the things that I saw in the state your topic, difficult topics in chemical pathology. So I'm going to take the acid-base balance and attempt to deal with it. I hope you're all okay with that. Hello?
Yes, please.
Okay, with
Good. The acid-base balance is a concept that can be very confusing if you don't pay attention. You need to pay attention to this lecture. Okay. Can you all see my slide? Am I sharing?
Yes, doc. Yes, please.
I'm sharing the acid-base balance, isn't it?
Yes, please.
yeah.
Okay. All right. So let's take the lecture again. I'm going to focus on the very important part of the lecture. So I'll skip a lot of things, not because they are not important, but because this is supposed to be a bulletin lecture, a lecture that should be on science and give you the fine details that you need to know. I cannot do everything. Good. Technically, in our stomach, we have all established that there's hydrochloric acid in our stomach, isn't it? That we know. That the parietal cells of the stomach secrete protons, and chloride moves along from the blood and joins it in the lumen of the stomach to form hydrochloric acid. So the acidity of our stomach is guaranteed by a proton pump from the parietal cells that allows us to acidify the stomach. So because acid is in the stomach, when you are curving the duodenum, all the enzymes that function in the duodenal area are actually basic enzymes. So secretin, a hormone, is produced to stop further acid production, initiated by cholecystokinin. What then happens is that then the duodenal pancreatic acinar cells then secretes a basic rich fluid containing a lot of enzymes and bicarbonates to make the medium of the duodenal area to the anus basic, so that the basic enzymes can also function. The enzymes that function in the stomach are acidic enzymes. From the duodenum going, they are basic enzymes. So in your intestine is base, in your stomach is acids. So let me give you this scenario. If I wake up from morning at dawn and I've been vomiting all day, the whole day for 2 hours I've been vomiting, what do you think I will be losing? Acids or bases? I'll be losing acids. So if I lose acids from vomiting, it means my body will have a deficit of acids. And so what pathology will I develop? I will develop alkalosis or alkalemia, simply because the acid and the bases are actually a scale of a balance. Acidosis is an increase in acids or a decrease in bases. Let me use a black pen and a red pen to demonstrate. I'm sure you can see me, but I cannot have a black pen. Black. A red pen. Red pen. Black. Or a red marker. Red marker. I have one here. Don't worry. I've seen it. Good. Students, I hope you can all see me.
Yes, please.
Good. So you are watching me, my video. If you can't see me clearly, let me adjust my screen so that you can see me. So we are simply saying that the red marker is the acid. The black marker is the base. When the acid increases, you get acidosis. Sometimes you will get acidosis when there have been no change in acids, but there was change in base. Why? The bases have decreased. Acidosis is an increase in acids or a decrease in bases. Because when the acids decrease, the acids are now more, so you develop acidosis. But if the acids don't increase, but the bases themselves decrease, it simply means that the acids now are comparatively more than the bases, even though the concentration of acids have not changed. But because the bases have decreased, then the acids become more than the bases, even though they haven't increased in concentration. And so we call that as acidosis. So acidosis is an increase in acids or a decrease in bases. Alkalosis is an increase in bases or a decrease in acids. So when the basis increases, then we say alkalines have increased, so you get acidosis. Sometimes there's no change in the basis at all. There's rather a change in the acids. The bases remain constant, but your acid levels decreases, you lose them. You will still develop alkalosis, because when the acids decrease, it gives a relative advantage to the bases. So the basis seems to have increased relatively. So acidosis is an increase in acids or a decrease in bases. Alkalosis is an increase in bases or a decrease in acids. I have woke up in the morning and I'm vomiting all my stomach contents. I am losing acids, so I will develop what we call alkalosis. That alkalosis is metabolic alkalosis. Why? Because it doesn't have anything to do with carbon dioxide or breathing. It is just vomiting. We only say respiratory when it has to do with carbon dioxide or breathing. So I woke up in the morning. I am not vomiting, but I am running diarrhea. I've gone to the loo about 10 times. Everything is coming out from my anus. What do you think I'll be losing? I'll be losing bases. Because from my duodenum going down, it's a basic medium. If I lose the basis significantly, what pathology do you think I'll develop? I will develop acidosis, because I have lost the basis. So the acids get a relative advantage. So that acidosis has nothing to do with carbon dioxide or breathing. So we call it a metabolic acidosis. There are 3 areas in the body that regulate acid-base balance. When a child accidentally drinks acid that you are put in your kitchen, the first agent to come to the defense of the child is the chemical buffers in his blood. The chemical buffers in the blood, they react rapidly in seconds. If the chemical buffers cannot deal with the excess acids, then your respiratory system comes in. We'll come and see how the respiratory system compensates. If the respiratory system cannot deal with the excess acids, then your kidneys come in. Of course, I don't have to now tell you buffer systems. From your chemistry, you should know what buffers are. Buffers mop up excess acids or excess bases. So that one is clear. What about respiration? How does your lungs help in acid-base regulation? We all know that when I'm breathing in, I'm breathing in oxygen. When I'm breathing out, I'm breathing out what? Carbon dioxide. Good. But we all know from our acid-base lecture in school that carbon dioxide is a volatile acid. It is considered as a volatile acid. Why? Because carbon dioxide reacts with water and form H2CO3, carbonic acid, which dissociates in an equilibrium to give us a proton and a bicarbonate. So the more carbon dioxide you have that reacts with water, the more carbonic acid will form. So whenever there's carbon dioxide, water is abundant in the body. So whenever there's carbon dioxide, it reacts with water to give us carbonic acid. So the more carbon dioxide there are, the more carbonic acid there are. So we consider carbon dioxide as a former of carbonic acid. So we say carbon dioxide is a volatile acid. So if I come and stand in front of you and I'm breathing fast, I'm hyperventilating, what do you think I'm doing? I am losing a lot of carbon dioxide. Because I am losing a lot of carbon dioxide, the equilibrium shifts from carbonic acid towards formation of carbon dioxide and water, and I keep breathing them out. So I will be losing carbonic acid. So I will go into a state of alkalosis, because anytime you lose acids, you develop alkalosis. But that type of alkalosis, because it has to do with carbon dioxide or breathing, we call it as respiratory alkalosis. Assuming I come and stand in front of you and I cannot breathe well, I'm breathing slowly. Slowly. What do you think is happening to me? I can't breathe out enough carbon dioxide. I can't breathe out enough carbon dioxide like I should. So I am accumulating carbon dioxide in my blood, and carbon dioxide, the more it accumulates, the more acids I form. Carbonic acid, H2CO3. So because of that, when I breathe slowly for a long time, I will develop what we call acidosis, because I am accumulating carbon dioxide and carbonic acid. That type of acidosis, because it was caused by accumulation of carbon dioxide and breathing problems, we call that as respiratory acidosis. When the respiratory regulation reacts in minutes to a much the level of acid onslaught, the lungs come in by hyperventilating or hypoventilating. When the lungs cannot deal with the problem, the master regulator, the kidney, now comes in. What does the kidney do? The kidney has a proton pump in the renal tubules that pumps acids out of the renal tubules. So when you have so much acids, the kidney pumps the protons acids from your blood and it acidifies your urine. So you produce an acidic urine with a pH below 6.5. But if you have alkalosis, you have excess acids, your kidney will prefer to hold on to the acids and rather lose the bases, so that it can use the acids it has retained to balance the excess bases in the alkalosis. So in an alkalosis, you would rather produce an alkaline urine and not an acidic urine. That's the job of the kidneys.
Doc, please can
Yeah.
you go again from the respiratory regulation?
Good. Respiratory regulation. I'm saying that, but we all agree that carbon dioxide is a volatile acid. That one we agree, isn't it?
Yes, please.
Good. So, if carbon dioxide is a volatile acid, and I begin to breathe faster, at a faster rate, what do you think I'll be doing? I'll be getting a lot of oxygen, yes, into my body, but I'll be losing a lot of carbon dioxide. So I am losing acids. So if I hyperventilate for a long time, it means the acids in my body will be reduced, because once I lose carbon dioxide, the carbonic acid will be lost. So my body will now get more bases than acids, because I have relatively lost some acids. So I will develop excess bases, which is called alkalosis. But that type of alkalosis, because it was engineered by breathing rapidly and carbon dioxide was lost, we now call that type of alkalosis as a respiratory alkalosis. Let's assume that I come and I am breathing slowly, shallow, slow breathing. I will not be getting enough oxygen. I will also not be sending and losing enough carbon dioxide. As I am not losing the carbon dioxide in exchange, I'm not breathing out adequate amount of carbon dioxide. What is happening to carbon dioxide? It is accumulating in my lungs. Eventually, it will accumulate in my blood. The more carbon dioxide in my blood, the more the carbon dioxide reacts with water to form carbonic acid. So, as I'm breathing slowly, I'll be accumulating carbonic acid in my blood. Eventually, the acids in my blood will be so much compared to the bases. So I will develop excess acids, and we call that as acidosis. But because that acidosis resulted from accumulation of carbon dioxide or breathing slowly, we call that as a respiratory problem. So we say respiratory alkalosis. Sorry, this is an acidosis. So it is respiratory acidosis, because if I'm not breathing well, I am accumulating acids in my lungs. The acids accumulate and causes an acidosis, but that acidosis is respiratory. So it is respiratory acidosis. It is the hyperventilation that causes respiratory alkalosis. Is it clear, madam?
Yes, please.
Good. So let's
Thank
move.
you.
You see that when I was talking about the vomiting and the diarrhea, I never said respiratory. I said metabolic. Because it has nothing to do with carbon dioxide or breathing. So you see, when we say metabolic acidosis or metabolic alkalosis, and when we say respiratory acidosis or respiratory alkalosis. Good. Permit me to focus on the most important part of the lecture. Good. Proteins, fruits and vegetables, sources of hydrogen ions. When we eat proteins, meat or meat products, the breakdown leads to the production of sulfuric acid and phosphoric acid. Sulfuric acid and phosphoric acid are part of the acids of the body. So when I eat meat, I increase my acidic content. I will develop acidosis. Too much meat. Acids. But when you eat fruits and vegetables, the breakdown of the fruits and vegetables produces bases, which can help to equalize the excess acids. So you don't just go and buy fufu and go and buy banku and buy plenty meat without vegetables. That's why when you eat food, we say you balance the food with vegetables. Some full course meals and you have vegetables attached. Because your body, in using glucose to do respiration, already produces excess acids, you need vegetables and fruits to give you bases that you can use to balance the excess acids. I'll come to this. Good. Parietal cell in the stomach. Part of acid-base balance happens in the stomach and the duodenum. Excuse me, class. Let me take this call. It's an important call. Yeah, hello. Hello. Quickly summarize what you have to say. I'm in a lecture. Hello. Yeah, good evening. Eh? In your office, in your online lecture. I'm having a lecture online. All right. Thank you very much for understanding. It's an important call from somebody who needs me. Good. You see, in the stomach, if you watch this diagram very, very carefully, the diagram in front of you, the parietal cell of the stomach is the one that produces the proton, the hydrochloric acid. How do we produce the acids into the lumen of the stomach? Here is the lumen of the stomach, the sac. This is the epithelial surface of the stomach, the parietal cell. And this is the blood vessel that links the stomach. So when we eat food, the food is digested here, absorbed across the parietal cells into our blood. Then it is distributed to the rest of our body. So this is the stomach sac, the space in the stomach called the lumen. And this is the parietal cell. And this is the blood capillary that links the parietal cell. In the parietal cell, carbon dioxide and water react. They form carbonic acid, which dissociates to proton and bicarbonate. Proton is an acid, bicarbonate is a base. In order to ensure that the lumen of the stomach is acidic enough to allow the acidic enzymes to function, the parietal cell pumps this proton, this hydrogen, into the lumen of the stomach. It mixes chlorine to form hydrochloric acid. But once the proton here is pumped into the lumen of the stomach, we leave bicarbonate. If we continue to pump the proton into the lumen of the stomach, we will develop alkalosis in the parietal cell because only the bicarbonate is left, which is a base. The more bicarbonate that accumulates, the more the parietal cell becomes basic and develops alkalosis. So we don't want to leave the bicarbonate in the parietal cell. Once we have sent the proton to the lumen of the stomach, we now send the bicarbonate into the blood. In the blood, buffers, chemical buffers in the blood will buffer the bicarbonate base. So in the stomach, we have acidified the lumen of the stomach and we have alkalinated the blood. And we call this as the alkali tide. It is the reason why when you eat food, immediately your pH goes into the basic medium. Because once you eat food and the food lands in your stomach, the protons are pumped to digest the food. Then the alkaline bicarbonate is sent into your blood, raising your pH into the alkaline medium. So that is called the alkali tide. The tide where immediately you eat, your blood pH gets more basic than acidic. So this is with respect to the stomach. Let's go to the pancreas. In the pancreatic cells are called pancreatic acinar cells. In the stomach, we were dealing with the parietal cells of the stomach. They were secreting protons in the lumen, acidifying the lumen of the stomach, and then secreting bicarbonate into the blood, alkalinating the blood. What happens in the pancreas or the duodenum? The pancreatic acinar cells, they want to make sure this is the duodenum, this is the intestine, this area, that is the duodenum. So the pancreatic cells also they produce a proton and bicarbonate by reacting water and carbon dioxide to form carbonic acid, which dissociates to give us a proton and bicarbonate. But here in the duodenum, we will rather pump bicarbonate into the pancreatic lumen of the duodenum to allow for the basic enzymes to continue protein digestion and the digestion of carbohydrates. But then, if we pump the bicarbonate into the lumen of the intestine, then the acid remains in the pancreatic acinar cells, which can cause the acinar cells to become too acidic and develop acidosis. So what we do is to pump the proton into the blood. The chemical buffers in the blood will now mop up the excess proton. So in the duodenum, we rather alkalinate the lumen of the duodenum and we acidify the blood. It is the reverse of what we did in the stomach. In the stomach, we acidify the lumen of the stomach and we alkalinate the blood. In the duodenum, we alkalinate the lumen of the stomach and we acidify the blood. We are very process. It is part of acid-base balance. It is a natural way where we balance acid-base.
Is it the duodenum or in the pancreas?
No, the pancreas releases its contents into the duodenum.
Okay, okay.
Are you okay?
Yes, please. Thank you.
Good. So the stomach and the duodenum, or the parietal cells and the pancreatic acinar cells, are all involved in the body's acid-base balance. And that is what I've just demonstrated to you. So this slide tells you that in the gastric mucosa, what we do is that we end up acidifying the lumen of the stomach and we end up alkalinating the blood. In the duodenum, we actually alkalinate the duodenal lumen and we acidify the blood. That is part of acid-base balance, homeostatic acid-base balance. So let's take it one by one. Respiratory acidosis, respiratory alkalosis, metabolic acidosis, and metabolic alkalosis. What is it? Forgive me if I focus on the very important points that I believe will make you easily understand. So we'll come back to some of these slides, but I need to break it down for you, a diagram. How do we use laboratory data to diagnose respiratory acidosis, respiratory alkalosis, metabolic acidosis, metabolic alkalosis? So this lecture is partly going to, in the early part, the diploma holders should follow. As we go along deeper, it is the degree people, I'll tell you what you should know. And then by the time we are getting to the end part, the Doctor of Medical Science people, you should understand what is called compensation, whether compensation is adequate or not. That is your job, because you have a role in clinical decision making. Good. I'll come back to most of these, but let me focus on this. Good. I hope everybody can see the slide. Hello, class.
Yes.
I hope you can see this.
Yes, we can see it.
I always love explaining this. I get excited in explaining it most of the time. Acid-base balance. Please, if you have ever been confused about acid-base balance, open your mind. This is an opportunity to grasp it once and for all. When I give you a laboratory data, it includes the pH of the patient, the partial pressure of carbon dioxide, partial pressure of or concentration of bicarbonate. This is all that you need to evaluate a patient, whether he has respiratory acidosis or respiratory alkalosis. whether it's metabolic acidosis or metabolic alkalosis. This is all you need. The rest are addendums. So when you get the data of a patient, the first thing you look for is the pH. What is the reference range of pH? pH of reference range is 3.65 to 3 point what? Oh, sorry. Hey, 7.45 to 7.65. Excuse me. Oh, this person. Hello. Yeah. Okay. No, what happened? Hey, just use your F insurance. That means what? That you did. But is it true that you are winning? But you didn't pay. Well, you have health insurance, so can you access another hospital? The care you need, can't you get it in another hospital? Yeah. Like the municipal, don't they provide that service that you are looking for? So try municipal hospital. If I cannot deal with the issue now at this moment, I will deal with it in an hour's time when I finish my lecture. There's not much I can do until I finish this lecture, then I can make calls. Okay? Yeah, hello.
Yeah, Doc, we can hear you.
Yeah, so let's continue. There's a med-lab student who is struggling with the health, but I'm sure I'll deal with that later. Yes. So the pH of the blood is 7.35. Please write it down. 7.35 to 7.45. That's the reference range of the pH. If you go below 7.35, then you are developing acidosis. If you go above 7.45, then you are developing alkalosis. So for this patient, when we check his pH, the pH has increased. That is, it is above 7.45. So what do we say? What disease that the patient has? Alkalosis. Is that not it? When you get below 7.35, you have acidosis. When you go above 7.45, you have alkalosis. So this patient, from this diagram here, when we check here, the arrow is going up. It simply tells you that his pH had increased above 7.45. So we conclude that this patient has alkalosis. We now go and look at his carbon dioxide concentration and bicarbonate concentration. So we compare his carbon dioxide to the reference range and compare his bicarbonate to the reference range. When we compare the carbon dioxide, we realize that the carbon dioxide levels have decreased. Once we realize that the carbon dioxide levels have decreased, carbon dioxide is an acid, isn't it? Please, everybody unmute yourself. Everybody unmute yourself. Latif,
yes.
Please unmute everybody.
Okay. I think they can unmute. So they can unmute themselves. I think they can unmute themselves. I've allowed them to be able to do that. Okay. Hey. You can hear. Hey. Doc,
Oh my God, no problem. Emma, the job you found.
Hey,
Oh,
Doc, you cause trouble.
Emma.
The things that are happening at the background.
Oh my God, yeah.
But who all come inside? Doc, can we contain this?
Yes. Latif.
Yeah, Doc.
I've muted everybody. We are fine. I don't think I could have. I can take it. But normally when I'm doing this, I prefer the students saying a lot of yes, no, following me in the lecture.
Yes, these students are mature students.
They
are in the house and some are.
Yes. Babies are crying, husbands are giving pecks, and wives are waving at husbands. I beg. Let's go with this. So I'm simply saying that we have established by looking at the pH to the reference range, the pH is above 7.45. So we conclude that the patient has alkalosis or is in a state of alkalemia. Good. We now come and look at the carbon dioxide. If the carbon dioxide is decreased, when we compare the carbon dioxide that the patient has to the reference range, we realize that that carbon dioxide is less than the reference range value. So carbon dioxide levels are decreased. Then we have to now ask ourselves, carbon dioxide is an acid. If acids decrease, can that cause alkalosis? Yes, because alkalosis is an increase in bases or a decrease in acids. So if carbon dioxide decreases, that can cause alkalosis. So the patient could be suffering from respiratory alkalosis. It's a possibility. We now go to the bicarbonate. Bicarbonate is a base. And then we ask ourselves, when bases increase, can that cause alkalosis? Yes, alkalosis is an increase in bases or a decrease in acids. So both of these conditions can cause the increase in pH. So we say the patient could either be suffering from respiratory alkalosis from the decrease in carbon dioxide, or a metabolic alkalosis from an increase in the bicarbonate. Beautiful. We go to the next patient. So what we have now established is the initiating pathology. We have now told you that a decrease in carbon dioxide could have started the process of the alkalosis, or an increase in bicarbonate could have started the process. Remember, there is also a compensation. Here, none of them is compensatory. All of them are initiating pathology. They are causes of the pathology. But let's come to patient number 2, the second line, this patient. For this patient, we realize that when we compare this carbon dioxide, the carbon dioxide levels have decreased. And then we ask ourselves, when carbon dioxide, which is an acid, when it decreases, can that cause alkalosis? Yes, because alkalosis, this alkalosis is actually defined as an increase in bases or a decrease in acids. So if carbon dioxide has decreased, that can cause the alkalosis. So the patient could be suffering from respiratory alkalosis. Then we come and look at the carbon dioxide. The carbon dioxide is normal. It means there is no compensation. Remember, we said that if the problem comes from respiratory, we expect the kidneys to compensate. The kidney changes bicarbonate levels, and the lungs changes carbon dioxide levels. So if we say the process is a respiratory alkalosis, it means the process was caused by the lungs. The disease was caused by deficits in the lungs function. So we expect the kidney to compensate by the kidney decreasing bicarbonate levels. Anytime there is excess bases, we expect that the kidney will actually come in to say that because the bases are so much, then I would rather lose the bases and hold on to the acids to compensate the decreasing acids with the decreasing in the bases. If acids are decreasing and there is now excess bases, I rather need acids to compensate for the excess bases. So the kidney will rather lose the bases. So the kidney will continue to lose bicarbonate, which is the base, and leave the acids so that it can use the excess acid it is now storing to compensate for the excess bases, which cause the alkalosis. So if the kidney is losing the bases, we expect the bicarbonate levels to decrease. Here, bicarbonate has not decreased. So we say the kidney has not compensated for the respiratory alkalosis. So we call it as an uncompensated respiratory alkalosis. If the kidney had compensated, the kidney will have lost a lot of the, because we are in an alkalosis, the kidney will have lost a lot of the bases. And so bicarbonate concentration will have decreased as the kidney loses more bicarbonate. So we'll have expected the bicarbonate to decrease. But here, that has not happened. The bicarbonate levels remain normal. So the kidney has not compensated. So we say uncompensated respiratory alkalosis. We now come to the third patient, this patient, the patient in this line. We say, we look at the carbon dioxide levels. The carbon dioxide is normal, and carbon dioxide is normal. If carbon dioxide is normal, then carbon dioxide cannot be the cause of the pathology. So what then do we do? What then do we do? We move on to the next analyte, which is bicarbonate. Bicarbonate is a base. Bicarbonate has increased, and bicarbonate is a base. When bicarbonate, which is a base, increases, can that cause alkalosis? Yes, because alkalosis is an increase in bases or a decrease in acids. Here, the bases have increased, so that can cause an alkalosis. So the initiating pathology, the cause, is the increase in bicarbonate. So if it is bicarbonate, then it is not because of carbon dioxide. So it's not respiratory, it is metabolic. We only say respiratory when carbon dioxide is the cause. So here we say because it is bicarbonate, we say it is a metabolic alkalosis. In a metabolic alkalosis, it means the disease was started by kidney deficiencies. The kidney is the one that caused an increase in the bicarbonate. We expect the lungs to compensate. If there is excess bases, what do you think the lungs can do? There's so much base. You need more acids to balance the bases. So the lungs will begin to hypoventilate. When we decrease our ventilation rate, we will accumulate a lot of carbon dioxide. And so we will get an increase in the carbon dioxide in our blood. So if the lungs will have compensated, then this carbon dioxide should have increased the same way bicarbonate increased. Before we can now say it is a compensated metabolic alkalosis. But as it stands now, the lungs have not compensated because the carbon dioxide is normal. So we say uncompensated metabolic alkalosis. Then we now come to the fourth patient. This fourth patient. We looked at the carbon dioxide. Carbon dioxide has increased. Carbon dioxide is an acid. When acids increase, can they cause alkalosis? No. In order for an acid to cause alkalosis, it has to decrease. So this is not an initiating cause. This one is probably a compensatory response. So we go and look at the bicarbonate. Bicarbonate is the base. Bicarbonate has increased. When bicarbonate increase, can that cause alkalosis? Yes, because alkalosis is an increase in bases or decrease in acids. So the process is metabolic. So we say it is a metabolic alkalosis. Then we now come and look at why the carbon dioxide increase. In a metabolic alkalosis, where there is so much basis, what do you think the lungs can do to help in the compensation? The lungs will hypoventilate. You breathe less faster. The more you breathe less faster, the more you accumulate carbon dioxide in your lungs. So your carbon dioxide concentration in your blood will begin to go up. Has carbon dioxide gone up here? Yes. So this is a compensation. So we now conclude and say this is a compensated metabolic alkalosis. The FMP you see there is full and partial. I will deal with that at the end of the lecture. At least there has been some compensation. Whether full or partial, we will now see how we determine if it is a full or partial compensation. Then we come to the last patient, this patient. When we look at the patient, his carbon dioxide has decreased. Carbon dioxide is an acid. If acids decrease, can that cause alkalosis? Yes, because alkalosis is an increase in bases or a decrease in acids. So here, when carbon dioxide decreases, it can give a relative advantage to the bases to appear to have increased. So that is what is causing the alkalosis. So carbon dioxide is the initiator of the pathology. So we say the pathology is a respiratory alkalosis. Then we now come and look at bicarbonates. In a respiratory alkalosis, there is excess acids, but the one who caused the problem is the lungs. So we would have expected the kidneys to help in the compensation. What would the kidney do when there is excess bases? The kidney now needs acids to balance the excess bases. So the kidney would rather lose bases, it will lose bicarbonates and conserve acids. So if the kidney begins to lose the bases, then the bicarbonates should have decreased. Has that happened? Yes, bicarbonate has decreased. So this means that the kidney has compensated. So we say it is a compensated respiratory alkalosis. Interestingly, when we meet in the next lecture, we will take the decrease, go and focus on the slide, try and understand it. If you have any questions, unfortunately, I am fasting, so I have to quickly get home and prepare something to eat. So I'll end the lecture at 6 o'clock. So we will continue next time we meet. I'm sure the coordinator, Mr. Abdulatif, will actually tell me when we are going to have another lecture. Please, I have told Mr. Abdulatif that I need time to make up for the lost time when I was at a place where the network was bad. So I couldn't engage you people. So I'll need another 2 hours or at another time to make up for the 2 hours lost. Thank you very much, class. If there are any questions, I will take them before I leave. I'm going to the chat. Somebody's questions. He says, we know that most fruits and vegetables are acidic. Who told you that? That's not true. The fruits that are acidic are known. Orange, pineapple. Those are the fruits that are acidic. Huh? It's not all fruits that are acidic. Vegetables are largely not even acidic. So don't deceive yourself. But nutritionist, am I right or am I lying? Yes, yes. So the fruits that are acidic are known. Yes, yes. Those are the citruses. We call them citruses. The large number of vegetables are not acidic. They are basic. Okay? Good. So that's the correction. So please, apart from balancing the food we eat, does the body has its own way of neutralizing acid and bases? Yes. We have just shown you what happens in the stomach and the duodenum. I've also just shown you what happens in terms of food that we eat. So we can even use briefings to control acids and bases. So the body has a lot of mechanisms to control acids and bases and balance them. So I'm told that you have pathology lecture from 6:15. It's already 6. Is it 6:8 or 6:3? I think it's 6:3. That's what my watch is saying. Please, how do you decide which side is the initiator of the disease? The size whose increase or decrease agrees with the pH. That is the initiator. For example, if the pH is less or the pH is acidic, so it's less than 7.35, you come and look at the carbon dioxide. If carbon dioxide has increased, yes, an increase in carbon dioxide, it's an acid. It can cause a decrease in pH. So carbon dioxide is the initiating pathology. That's how you determine. But if you look at the bicarbonate, and the bicarbonate has also increased. Bicarbonate is a base. When bases increase, that cannot cause acidosis. That cannot cause a decrease in acids. So the base increasing does not agree with the pH. So the base bicarbonate increasing can only be compensatory. It cannot cause the pH that we are seeing to be decreased. So we say that is the compensatory cause of the pathology. So the initiating pathology is the carbon dioxide. That's how we determine the initiator and the compensator. Thank you very much. So I cannot see any questions. So I assume that Abdul Latif, my senior Latif, I assume that there are no more any questions for me to deal with.
Yes.
So I will be waiting for you to tell me when we are meeting again, and I'll prepare for the next lecture.
Okay.
In the next lecture, I'll try and finish the acid-base balance, and I'll try and take a few of what I call maybe the liver, the kidney function test. Okay, because I've seen renal function here, and then I'll try and do some little bit of hormones endocrinology. I can see it cutting across. Then we'll probably do some, if I have time, I then do some enzymes, hormones, and maybe electrolytes, if we have time.
Okay.
Thank you very much.
Thank you to Doc.
So, Senior, I can exit the page, right?
Yes, you can. We'll arrange for the next lecture for you.
Thank you very much.
Okay.
Class, please, everybody can now unmute. I want to ask them, are they okay with my lecture? Is there any problem? Is there something they want me to correct in the next lecture?
On a personal level, I think it's been great. Thank you, sir.
Good. Thank you very much. I'm grateful for that feedback. I'll meet you at the next lecture, okay?
All right, sir.
We need the slide.
The slides, I'll send them to Abdul Latif, my senior. Okay.
Okay.
Thank you. Ayekao.
Babies are crying at the background.
Ayeka.
Okay, so please let's stay on, or you can exit and return in about 10 minutes for the pathology.
Okay, Joan.
Hello. Hello.
Hello, Doc.
Good evening.
Good evening, Mom. You're welcome.
Thank you. How are you doing?
We are doing great.
So how are the lectures going so far?
So far, so good. We just finished with the chemical pathology.
Oh, okay. So that's
So
why you don't
I think we were given some 10 minutes to
relax before.
Yes. Yeah.
Okay, wonderful. So we'll start at 6:20. We'll give extra 4 minutes.
Okay.
Okay, so it is 6:20, 6:21. So continue with our lectures on tissue processing. So yesterday we spoke about the various stages in tissue processing. We talked about dehydration, we talked about clearing, we talked about infiltration, and then we started with embedding. So we talked about the fact that orientation of the tissue is one of the important things to consider when you are doing embedding. And it is advisable to do embedding with the grossing information so that you'll be able to tell whether the tissue is a hollow tissue or is from epithelial surface where it needs to be embedded on the edge. So any other tissue apart from those with epithelial surfaces, hollow, those with spaces within or have epithelial cells as the lining, or the cells are layered, the tissues have layers of cells, then you embed on edge, but any other tissue you embed flat. So we ended up with alternatives to embedding media. So we said that routinely the embedding media that is used, or embedding medium that is used, is paraffin. So everywhere you go for normal histopathological work, tissue processing, or embedding, paraffin wax is used. But there are certain situations where paraffin wax will not be ideal, especially when you are going to do electron microscopy. When you are doing electron microscopy, you need very thin sections. And so you need to get a medium that is hard. If the medium is soft, it is difficult to cut thin sections. So if the medium is hard, then you'll be able to cut thin sections. And also if the tissue is soft, it's very soft, you also need to use embedding media that is softer than paraffin to use. And then if, let's say, you need to preserve certain components in the tissue for staining, or either routine staining, or for immunohistochemistry, or for molecular methods or something, then you need to preserve those components, and then you don't need to use embedding, or you don't need to go through paraffin embedded processing. Okay. Sometimes you need to as I've mentioned, preserve certain proteins in the tissue, and so you need other forms of processing other than the paraffin embedding process. So let's look at some examples of other embedding media that are available. So we have resins. So resins are the hardest of all the embedding media, and it is usually used when you're going to do electron microscopy, as I mentioned to you, because it is hard and it can be able to produce very thin sections. You know, electron microscopy, you need very thin sections because you want to see the details of the cell. You want to see every minute detail of the cell. And if it is thick, you will not be able. So you cut less than a micron of a section, and you need a medium that is hard to be able to do that. And also sometimes you don't need to, especially if the tissue is calcified, you want to examine the tissue in its calcified state. You don't want to decalcify it. And so you need a medium that is hard to be able to hold the bone for sectioning to be done. So you use resin. Gel or agar. Agar is also used, especially if you want to do double embedding, where maybe you have tissue fragments. And if you put it directly in the process, the tissue processing technique, you may lose the samples, even though sometimes you can color them and all that. But sometimes they are so small that you may lose them, or maybe you have cells. You have processed your cytology samples. You have enough cells. You want to preserve the cells for future use, so you embed them first in agar. So just like the agar is just like the one that is used for for culture and sensitivity. So what you do here is that you create a hole in the agar when it is setting. So you can put something in the middle somewhere, so that when you remove that thing, when it's setting, you remove that to create space in there. Just that you make sure that it doesn't go through. It shouldn't go through, because if it goes through, then when you put your fragments or your cells in it, then it will when you take it out, it will move out. So you create a space in it, then you add your fragment or your cells in it, and then you seal it up, and then it goes through the normal tissue processing. Okay. So you also have gelatin. So gelatin is also used to produce sections from whole organs. So let's say you want to embed a whole eye. Let's say eye, you don't want to cut open the eye. You want the whole eye to process. You can use gelatin. Or maybe you are doing frozen sections. You want to use frozen sections. You can also use gelatin. Okay. And then solid is not commonly used because it has some disadvantages, but I don't know why they are still maintaining it as an embedding media, because it is rarely used and it doesn't really provide the required. It needs specific requirements because of the way it has low viscosity. So working with it is not very favorable, but still occasionally other people uses them. But it has several disadvantages. So now there has been improvements, or there has been a step up in the processing of tissue. So to enhance or to facilitate the turnaround time, to be able to produce sections or to process tissue in a fastest rate, some new techniques have been introduced. some advancements have been introduced. One of them is the microwave. So the microwave, we all know microwave, like a normal microwave. It uses heat. And as we were talking about factors that influence tissue processing, we mentioned the fact that heat also influences processing. So when you have microwave, it fastens the time within which to process the tissue. And also it enhances penetration, it reduces the turnaround time, and it provides good morphology, because you are not going to use formalin, you are not going to use xylene. And formalin causes what? Denaturation or cross-linking of proteins. But in this case, it doesn't happen like that. And then formalin and the other alcohols and other chemicals that are used processing, also like xylene, for example, also causes shrinkage and causes removal of certain components of the cell. But this one doesn't. Okay, so it has several advantages, just that it is cumbersome, very cumbersome, and you need to be very careful, because the time wasting will cause the tissue to be destroyed. So there is a need for to control the timing and the temperature very well to prevent destruction of the tissue. Okay, so as I mentioned, you don't need xylene, you don't need formalin in this case, because when you use this formalin, and it creates fumes which are poisonous. And so because of the heat, fumes are generated. So you don't use formalin, you don't use xylene, so you just use alcohol. Okay, so these are some of the advantages and disadvantages of microwave ovens. As I've mentioned before, you don't use formalin. It's also preserves the morphology well. It preserves the antigenic sites. So antigenic epitopes are easy to retrieve from samples that are processed with the microwave, because there's no denaturation of proteins, there's no coagulation of proteins, there's no cross-linking in that. Okay, and as I've mentioned, it improves the turnaround time. It's environmentally friendly, because we don't use these chemicals where you introduce heat and then it will produce fumes and other things. And then it also reduces the number of reagents that you are going to use. So if in the normal processing we use 2 or 3 changes of one type of alcohol, let's say 70% or 80%, this one you can only use one, because of the fastness, the heat that is there, that causes the penetration and causes the process to be fast. And then disadvantages, as I mentioned, it's very cumbersome because it's manual. So when you put the sample in a reagent in the microwave, you have to be sure to be there to change it when there's a need for a different reagent to be used. And so it is labor intensive. You need to be there all the time. Okay. And also it is expensive because of the microwave, but it's not as expensive as a tissue processor, but after all, the cost too is there. And then, as I mentioned, you need monitoring and calibration, timing, control. Very, very, very important. That's a disadvantage. So an advancement in the microwave oven is the constant throughput processor. So this also uses the microwave technique, but this one is not manual. It is automatic, but it has the microwave incorporated into it. Okay, so it just has advantages and disadvantages, just like the manual one. So you just use a processor that has microwave in it. So it uses the microwave. So it's automatic. Just that this one, you don't have to be there to control the time. Everything is set, just like the other processors. Okay. So as I mentioned, it's a human advantage and disadvantages. Okay, so now let's go to seasoning or microtomy. So after you have embedded your tissue, depends on the type of embedding medium that you use, you need to produce sections or very things like microns, between 2 to 4 microns or 2 to 5, depends on what you are using the tissue for, or sometimes lower or less than a micron because of what you are going to you want to use the section for. Okay. So the process of producing the section is called sectioning, or producing the thin slices called sectioning, and or microtomy. Microtomy because the instrument that is used to produce the section is called a microtome. So when you are using the microtome to section, it is called microtomy. Okay. So now let's talk about sectioning. So as I've mentioned, is a process of obtaining or getting thin sections from a tissue for a microscopy. Okay, and it uses advancing mechanisms. So the mechanism, the advancing mechanism may be from the blade, or maybe from the block holder. We'll talk about it as we go along. So when you take the microtome, as I mentioned, your microtome is equipment, or is equipment, is a machine. Okay, and it has a body, it has a part where the block, the embedded tissue that you have produced will fit. Yeah, so you have a block holder, and then you have a place for the knife, which will be doing the cutting. Okay, so you have a knife holder, and all these are regulated by knobs and clamps. Okay, so that you can easily remove them and you can easily fit them back. So you have clamps and knobs that you tighten up to make sure that everything is stable to be able to produce good sections. Okay, so the block holder may be the one, depends on the type of microtome you are using. There are several types we'll talk about on the way. Depends on the type of microtome that you are using. Sometimes it is the block holder. Usually the block holder moves. So the block moves forward and then the blade cuts. So the blade is stable. And then sometimes you can have the block being stable and then it's the blade that moves. So the blade moves forward to cut the sections as you turn, or as you turn the some handles on the microtome. Okay, so microtomy is one of the most difficult part of histopathology, because you need so much experience to be able to produce a section. You can't just, when you see somebody sectioning, you stand there and look at the person, you think it is easy. You go and stand behind a microtome and you see whether you'll be able to produce a section in 2 hours. Okay, so it needs very experience, so much experience to be able to section. So as I've mentioned to you, it uses what, blades and then knives. Okay, now recently the knives are not recently being used, but more of disposable blades. Okay, because now the microtomes that uses knives are no more being produced, because you can just imagine a knife, big knife. Some of them are so heavy you can't even carry. Those times I remember you had to carry them to the mortuary for sharpening, and they are so big and like cutlass. Even some of them are heavier and bigger than a cutlass. Okay, and we also had diamond knives, glass knives. Now those ones are not being used frequently. Once in a while they are used because of the, especially if you want to cut very thin sections, you need glass knives or diamond knives. Glass knives, and they become blunt. You can't use glass knives for more than 2 sections. You cut one, or it becomes blunt. So now what is being used is disposable blades. Okay, so disposable blades are the ones that are being used. So as I mentioned, there are different types of microtomes. So the normal ones that you see around, that is being used in Ghana frequently, the one that you turn it like a sewing machine, is the rotary microtome. We have one that is also rocking. So you have rocking microtome, you have base sledge. So base sledge is a heavy duty microtome that is used to calcify tissue. It's very heavy, very heavy. You have the sliding microtome where the blade is on top. The blade is on top. You have the ultra microtome that is used in the electron to cut sections for electron microscope. So these are examples of some microtomes. Microtome knives, I've mentioned some already. So I've mentioned that we used to have knives. Now we are using blades. And then we used to use diamond knives, glass knives to cut sections between 2 to 5 microns. So how do you use knives in during microtomy? Or blades. These are very sharp, because we are cutting very thin sections. Even let's look at our kitchen, for example. Those of us who cook, when you have a blunt knife and you are cutting, it's very difficult to cut with a blunt knife. So, and then if you are cutting with blunt knife, you can't cut certain thickness. You have to cut them big. Especially if you are cutting chicken, for example, and your knife is blunt, it's difficult to cut very small chicken. If you try to cut small, it becomes distorted and it doesn't look nice. So you have to cut it big. But if you are using very sharp knife, you can cut small slices of the chicken. The same thing here. If the knives are blunt, you cannot cut anything. You will have fault. You have a lot of issues with the section. So the knives are supposed to be sharp. A lot of people have had experience where the knives have cut. Some even have lost their fingers because of a disposable knife that is used for microtome. So the knives are very, very sharp. Okay, they are very, very sharp. So when you are using them, when you are handling them, you have to be careful. You don't look at it as if, oh, this is a very small knife. So no, or a small blade. No, it is very sharp. It's sharper than the way it looks. Okay, so anytime anybody is using these kind of things, you should be very, very careful. And also, when you are using the as I mentioned to you, these equipment, the knives are separate from the microtome. It is not attached. So if you want to use the knife, you have to bring it in. You have clamps and you have knobs that opens up the space for that in the knife holder for you to insert your knife. You clamp it back. So you clamp it back and then you use. So when you are using that, you have to be careful that you have clamped it well. Otherwise, if it is not well clamped, you'll be sectioning and it will come out and it can cut you. You can cut even your wrist out. It's very dangerous when you are using some of these things. Okay. And then if you also clamp it too much, it also creates some indentation in the knife, and then it can cause a problem with the sectioning. So you cut sectioning and the section becomes like concave sections, and you don't really get the whole surface of the tissue. Let me see, somebody has put a question. Oh, okay, it's not about me. Great. Okay, so let's go on. So if you clamp it too much, you have that kind of, and then you may not be able to get the whole surface. Okay, it will become like a hole. You see how holes are? Holes are curved sort of. So when you clamp it too much, it becomes curved sort of. So you realize that when you are using the hole, the edges of the hole doesn't cut like the middle. Okay, so if you want to cut the whole surface, it means that it's only the middle that will be cut, and then the sides of the tissue will not be cut, which is not ideal for a proper section to be produced. Because the microtome is a machine that is being used regularly, there is a need to maintain it, especially with the clamps and the knobs around. You need to oil it so they can be easily be operated or easily be turned around when you need it to be turned around. Then there should be proper maintenance schedule. Okay, so that every time they check whether everything is working normally, everything that is supposed to be the green are done, advancements in the various parts are achieved normally and all that. So there's a need for these maintenance to be done. It can be maintained weekly, monthly, quarterly, or yearly, or whatever, depends on the lab. Okay. So now let's look at what is required, what is needed for microtomy or for sectioning. If you want to section a block, what do you need to section a block? First, you need a block. You need a block that you have to section. Okay, you need a block, you need a microtome. If you don't have a microtome, you cannot section. So you need a block, that is the tissue that you're going to section. You need a microtome. Okay, you need a floating water bath that is temperature regulated. You need a hot air oven or hot plate. You need forceps. Okay, varied kinds of forceps. You need brushes. Okay, you need scalpel blades, you need racks, slide racks, you need slice. Okay, you need pencil. Usually, so far as pathology is concerned, because of the chemicals that we use for the processing of the samples, we don't use normal ordinary pen or ink or grease pencils. We don't use those ones, because by the time you finish the processing, they've been dissolved and they've been washed off, and it will be very difficult for you to identify the various samples that you are working with. So we use the lead pencils, okay, or chemical resistant pencils or pen. You don't use the normal pens. No, you need chemical resistant pens. So to avoid that, you use pencil. Okay, lead pencil. Okay, lead pencil, not grease pencil or colored pencil. No, lead pencil. Then you use an ice plate. You need ice plate or ice tray. Okay, you need that. So this is to mention but a few. So how do you get ready for microtomy? So you need to get your microtome and your seat. You don't stand to do microtomy. Some people stand because of the position of the microtome. So the microtome should be put on a flat surface, and it should be ergonomically positioned so that you don't stress your back or you don't stress your shoulders or in the process of producing section. Okay, you don't stress your neck. It has to be positioned in such a way that it will be easier for you to sit in a relaxed way to do the section. Okay, so usually it is set on a flat surface, solid flat surface, because the microtome itself is a heavy machine, and if it is not on a flat surface and it is lifted during the process, it can cause so much accident. It can destroy you, the microtomist, and then it can also destroy other things in the lab. It should tilt where it's supposed to be. So it always has to be on a flat surface. It should be stable. When you put it down, it has to be stable. Okay. And also you need to put on your water bath. So the water bath, as I mentioned to you, is temperature regulated. You have to regulate it lower than the melting point of the wax, because you are going to, after producing your section, the section is a paraffin embedded section. So you want to flatten it. So the water bath is used to flatten the section, make it more flattened, to make it more smooth. Okay. And so if you use a temperature that is about the melting point of the wax or more than the melting point of the wax, it will cause disintegration. Because remember, during the clearing, there are cavities that are created, and these cavities are filled with the paraffin wax. And so if the temperature is so high, and then the paraffin in the cavities are melted, you can just imagine it will break the tissue into fragments, into pieces, which is not what we want. We want everything to be intact. So usually you reduce the temperature of the water bath to about 5 to 10 degrees below the melting point of the wax, so that even though it is melted to make it flat, it doesn't melt it completely to disintegrate it, okay, to distort the tissue. And then you have your blade. You have to make sure that your blade is inside the blade holder. And usually the blade holder has a cover. Okay, so it has a knife. The knife has a blocker or a cover that when you are not using the knife, you use it to block. So you make sure that your cover is working. Some microtomes have the covers removed. So in that case, when you are going to, if you're not ready to use the knife, you don't place it in the microtome, so that you don't cause accidents to yourself. And as I've mentioned, the blade should be sharp. Okay, the blade should be sharp. It's only when when you are not going to produce the final section, we'll talk about trimming later. When you are trimming, you don't need a sharp blade. You just need any blunt blade. But when you are going to do the proper sectioning, where you are going to use it for microtomy, you need a very sharp. And one other thing that is also important is the angle by which you are going to cut the section, the angle between the blade and then the block. Because if that angle, which is called the clearance angle, is not set properly, you can produce sections that are not flat, or you can produce sections of just parts of the tissue, or either only the top part of the tissue or the down part of the tissue, which is not an ideal thing. So the clearance angle has to be set well. Usually the clearance angle is as I've mentioned to you, is the lower part of the blade to the surface of the block. Okay, so the angle between the lower part of the blade, the lower face, the lower facets of the blade, and then the block, which is usually between 2 to 5 degrees. Some other literature will say 2 to 7 degrees, others will say 3 to 8 degrees Celsius. So degrees. So any of them is applicable. Okay. But when you are using frozen sections, you can go higher, between 5 to 7. Maybe that is why people prefer to use the long range, 2 to 7 or 3 to 8, so that it can cover for all types of sections that one needs to produce. Okay. And also, as I mentioned to you, the knobs, the screws, and the clamps has to be tightened firmly, and then not too hard, not too tight, that it will cause the blade or the other equipment to be too tight that it cannot perform its function normally. Okay. So now let's go into the sectioning proper. So when you are sectioning, the first thing you do is, after setting up your everything that you need, your microtome set, your blades, you have your blunt blade for trimming, as I mentioned to you, we talk about trimming, and then your sharp blades that are going to use for the proper sectioning. If I say proper sectioning, it means that getting the section that you use for the microscopy. Okay, great. So, but before you produce the section that you are going to use for microscopy, you need to trim the block. And there are two main ways of trimming the block. One of the first trimming of the block is after embedding. You see, you have excess wax around the cassette. Okay, the cassette that has the label. And as I mentioned to you, there is a block holder, and this block holder is according to the size of the cassette. Okay, and so sometimes it may be bigger, you need to screw up to be able to fit it in. So when you have excess wax on the block and then you use it to trim, because you have put it in a metal and there has been some pressure on it, by the time you finish trimming, some of the wax on the cassette will be removed. So when you put it in back again for the normal sectioning, you may not have it placed in the same position as you use to trim it. And so you cut sections that are not producing the whole surface of the tissue, or you cut sections at a different angle, and it will create a mess with the sectioning. And so it is important that you trim the block, you remove every excess wax on the cassette, not on the block, the tissue in the tissue block, but on the cassette. Okay, because it is the cassette that you are going to position it in the block holder. Okay, and then you cut the block on the cassette. Okay, the cassette is just to hold the block. and then it has the label of the specimen on it. Okay, so you trim it. The second trimming is when you want to expose the surface of the tissue. So you have a tissue in it. Because of the embedding, the wax seals the surface of the tissue. Sometimes you can see. It doesn't mean that seeing the tissue there doesn't mean that it is not covered by wax. It's covered. That is why one of the criteria of choosing an embedding medium, that it has to be transparent or translucent, so that you'll be able to see the tissue inside the block. Okay, so usually the surface of the tissue is covered with wax, with the wax, and so you need to remove the wax to expose the surface of the tissue. Sometimes if you don't orient the tissue well, some parts may not be exposed, so you have some parts inside the wax, and so you need to cut the surface to be able to expose the whole surface of the tissue, so that when you produce sections out, the whole surface of the tissue will be examined, and then the correct diagnosis will be made and interpretation will be made. Okay, so that is the trimming. That is the two kinds of the trimming. So the second kind of the trimming that I was talking about, removing the surface, you do it at a higher micron. Some use 10, some use 20, some use 30. Depends on the person who is doing the microtomy and the experience of the person. Okay, so you just to expose the surface. It shouldn't be so big a micron that by the time you realize the whole block is removed from the surface of the block of the cassette. Because if you use higher thickness, you can lose it will be so much that you can remove the block from the cassette, and then you have to go back and embed. Sometimes they can destroy it in all. Okay, and also if the trimming has to be done not so fast. Okay, not so fast, not too slow too. Okay, so otherwise, if it is because you are using not sharp knives, and you may create some holes in it gently, so that you don't cause damage to the tissue. Okay, great. So now let's come talk about the actual sectioning, which is at the end going to be used for cleaning. So the actual sectioning. So as I mentioned to you, depends on the lab. Some will cut it at 5 microns, some will cut it at 3 microns. So it's between 2 and 5 microns. And then if you are going to use it for electron microscopy, or you need very thin sections, you can cut 10, we can cut 1 micron or 0.5 microns, depends on what type of microtome you are using and the blade that you are also using. Okay, and what you are going to use that section for. So as I've mentioned to you, you need to get your ice tray. So the ice tray is the one that you are going to use to cool both the block and then both the tissue and then the paraffin. Okay, so that it will be hard enough. I mentioned to you previously that when the tissue is hard, producing section is easy. Let's take chicken. When chicken is frozen and you're cutting, it's easier and it cuts smoothly and nicer than when it is stored. So usually you don't want it to cut to thaw. So when you go and buy the chicken from the shop or from the cold store, you make them cut it, so that by the time you get to the house, it will not be thawed and it will be difficult and it will give this serration at the edges of the chicken and it will not be nice. So usually chicken is if you want very nice shaped cut chickens, then you cut them when frozen. Okay, so the same thing when you are going to section, you want smooth surface sections, smooth thin surface. So you need to make sure that the block is hard enough. Okay, it's hard enough. So you cool it on ice block. Okay, so you have your ice tray. It can be any, so far as there is ice block in it, it can be any container at all. Then, and sometimes you can have the tissue being softer than the wax. So you need to harden the tissue a bit so that you have consistency with the wax. Sometimes with the wax too is softer than the tissue. So when you put it on the ice, both of them become cool, and then it increases the consistency and it brings some coherence between the tissue and then the paraffin. Okay. And then also when let's say you are sectioning and the tissue, is not that the tissue is calcified. Maybe in the process of in the processing schedule, there was delayed in one of the reagents, and that has caused the hardening of the tissue. And so you need to make it a bit soft. Okay, you need to make it a bit soft. So that once you place it on the ice, and then the water that melts out of the ice soaks up the tissue, or the tissue soaks up the water and make it slightly soft for swelling and for sectioning to okay. Very, very important. So one thing that you do when you are sectioning is determine the thickness of the section that you want to prepare. So or to produce. So there is a gauge or a calibrator on the microtome that you set to the how do you call it, to the thickness that you want. Okay, so it depends, the thickness of the section depends on what you are going to use the section for, the temperature, because as I mentioned to you, the temperature is high, you cannot produce thin sections, you produce what, thicker sections. And then also the knife angle, as I've mentioned to you, or the clearance angle also influences the kind of section, the thickness of sections that you produce. Okay, so the knife angle is the angle between the two faces of the knife. Okay, that is the knife angle. So the bigger the knife angle, the thicker sections you produce. The thinner, the smaller it is, the thinner sections you produce. So, and one other important issue about sectioning is the ability to produce ribbons. That is the ability to get the sections attached to each other. And this is created by the friction that is produced between the knife edge and then the block. So as you turn it, as you rotate the handle, and then it moves up and down, it creates this heat that causes the edges of the edge of the first one to melt to attach to the second one. So you have them in chains. You have series of the sections, and that is good because it enables you to choose the best of the sections. Enables, and then if you also want deeper sections, it's easier for you to select sections from the ribbons than cutting one block at a time. Okay, and then when you also produce, it produces ribbons, there is consistency between the thickness, but when you cut it one at a time, there is even though you have set the gauge to specific microns in which to cut, sometimes when you cut it one at a time, it shifts naturally. So you realize that you have one section that is thin, other thicker, then you have thin, thicker, thicker, like those ones. You don't have the same consistency of sections. But when you cut it in ribbons, when it comes in ribbons, it means that you're using the same split to cut. Then it produces the same thickness. So you can choose any of them, and it's easy to select the layer if you are cutting deeper sections. So you have a first section, and then about 2 or 3 more. After 2 or 3 sections, you should pick another level. Then after 2 or 3 sections, pick another level so that you can be able to study the tumor in details, how deep it has gone into the tissue. Okay. And then I also mentioned that you need what? You need brushes. So brush, you use it to transfer the section onto the water bath. Okay, so you pick after producing, you see that the ribbons will lie, or the section will lie on the surface of the knife holder, and then you use a brush to pick it up, or you can use forceps also to pick it up, or you can use your hand also to pick it up. and then you drop it on the surface of the water. Otherwise, you can also use, you can collect it, the sections, and then you don't place it directly on the water bath, but you can place it, you can flood it on a pes plate with a percentage of alcohol, between 20 to 50% of alcohol. So you flood it, and then it also helps to straighten up the section before you transfer it onto the surface of the water bath. So usually the water bath is not filled to the brim, but it should be filled in such a way that it should be easier for you to transfer the sections onto it and to pick the sections out of it. Okay. If you make it go in deep so much, if it is half of the water bath, it's difficult to do that. It should not be filled to the brim, but at least it should come a little down so you can have easy access to the water. So floating out of sections. So how do you float? As I've mentioned to you, you can pick directly and drop it on the surface of the water bath. Okay, and I've mentioned to you that the water bath should be between 5 to 10 degrees below the melting point of the wax. That has been mentioned already. So floating it, you can pick it directly, whether with the forceps, with a brush, with a teasing needle, or with a with your fingers. Then you drop it on the surface of the water bath. Or you can also use the alcohols, as I've mentioned, the 20 to 50% ethanol. You flood it on a pes plate, or is this pes plate is this plastic flat plastic where you put the section on it, and then you flood. So you use the tip. So usually the alcohol is in a container that has the pointed tip, so that you put the tip under the section, and then it floats on the surface of the section, and then it's easier to transfer it onto the. So you pour all back into the water bath, and then it helps in straightening up of your section. Okay. So sometimes when you float the sections, they are not they are too crumpled. They form folds, and so you want to release some of the fold manually. So you can use these teasing needles or forceps to open up the folds. So that one, you need a special experience to be able to do that. It is not as easy as I am saying it. So usually when you flood when you float the tissue on the water bath, you wait for about 30 seconds for it to for the wax to not melt completely, but become soft enough to flatten up. So when within that time, when it flattens, and sometimes it can go beyond, depends on the temperature of the water bath. So when you see that it has flattened up and everything is flat, there are no folds or anything in the section, then you pick it up with your slide. So you hold the slide 45 degrees to the surface of the water. You go in like that, the 45 degrees, and then you go close to the tissue. Make sure that the one edge of the tissue, the section that you have produced, touches the glass slide, and then you pull it out gently. So as you pull it out, it settles on the surface of the slide, and then you slant it on the surface for it to drain, the water to drain or to dry off. Okay. And because there is a possibility of mixing up or getting contaminants from other tissue blocks or floaters, that is section or fragments of tissue from one block being transferred to the other because of the same water bath being used. It is very ideal that every section that you produce, you clean the surface of the water bath so that you don't transfer debris from one block to the other. Otherwise, you can create confusion. If there is the first tissue, let's say, is a cancer tissue, the second is not, and then you manage to get a piece of that tissue onto the second tissue, then it means that the person is going to be diagnosed as having a cancer. Meanwhile, it is a floater. So you can clean the surface of the water bath with either the tip of one of the brushes or even a pencil. You can just tap it, tap the wax on the surface, and it is clean. Sometimes if the wax is not thick enough or gets there from the sections, it's thin, so you can easily use something to pick it up, or you can sweep the surface of the water bath with a paper, with a plain paper or a used paper or something that you sweep the surface with it, or you change the water completely. Depends on how the fragments are. Okay, great. So now after picking up your section, you drain it on a flat surface, maybe on a wall or on the even you can dry it on the, drain it, the either the side of the microtome or the water bath. So you slant it on the water bath for it to drain, to the water to drain. Then after the water had drained, you dry it further by putting it either on a hot plate or in a hot air oven, about 3 degrees higher about of the wax, so that can help. What is the use of this hot plate or hot air oven? It helps in the adhesion of the section onto the slide. Okay, it helps the section to adhere completely onto the slide, so that when you go through the staining process or subsequent processes, the section is not washed off. Okay, very, very important. And then you can also have a gradual drying of the section by keeping it in at 37 degrees overnight. So it takes its time to adhere nicely. Or if you want it within a few minutes, 15 to 30 minutes, then you can do it at the melting point of the wax or slightly higher, as I've mentioned. Okay, so now we are going to talk about sectioning of hard tissue. So as I've mentioned to you, one of the ways by which to section hard tissue, if the hardness is as a result of the processing, then you put it on the ice and let it soak some of the water on the ice, and then you can section. Sometimes too, the block may be hard. There can be micro calcification in it, which was not noticed before the processing. And so you need to do surface decalcification. So you can use phenol, as I mentioned to you, phenol for hard tissue. When the tissue is hard, you want to soften it. Either you use the water to soak it, or you can use 4% phenol. Okay. Oh, somebody is drawing angles on my screen. So please be careful, those who are touching. A message, let me check the message. Oh, okay. This is not for me. Thank you. So sometimes the softener will not be able to soften it. And I also mentioned to you earlier that you can also use glycerol and alcohol mixture as a softener. Okay. But sometimes if it is calcium, then you have to do surface calcification that you use about 5 to 10% HCl. Okay. So you soak it, you put the surface of the tissue in the 5 to 10% HCl for about 15 to 30 minutes or 1 hour, and then it softens up just the surface, and then you're able to cut your sections. Okay, because sometimes if you have these micro sections, like micro calcium in the section, it produces when you cut, because it is hard, it produces lines in between. Okay, we call it scores. Okay, it produces scores in between. Okay, in between the section, and the section, it doesn't, it's like that's cutting bread not with a bread knife. You know, when you are cutting bread with bread knife, it cuts smoother. Or when you use bread knife, that's, you know, the knife that they use to cut bread at the malls, is smooth. And so when it cuts smoother. But when you are using the serrated bread knife, you see that it doesn't cut it smooth. It cuts some, it has some rough surface. So the same thing, if you have calcium in the tissue and you cut, it's very hard to cut, and then it also creates this roughness on the surface of the block. Okay, but one thing that you have to be cautious of is that after using the calcifier on the especially the acid, or even if whether it's phenol or acid or glycerol alcohol mixture, you need to wash it completely, wash it out, and then put it on the ice for it to chill, and then before you section. Okay, because they will have, if you leave the acid there, it will have a negative effect on the section during the further processing of the section. So I've mentioned this already. So now let's look at some problems that are associated with sectioning. Okay, very, very important. So on this slide, I have, so this slide and the subsequent slides are talking about faults, like problems that are associated with the section and how you can overcome the problem. Okay, so the ways by which you can use to overcome the problem. So let's look at some of the problems. So one of them is producing curved sections, as I've mentioned to you. If the section is curved, okay, then it means that it is possible that the tissue is not flat. When you were embedding it, you didn't embed it flat. Okay, you didn't embed it flat. So part of it is indented. So the tissue curved during the processing period, and when you were embedding it, you didn't press it for it to be flat, and so it created that curve. And so when you get a tissue like that, you have to trim it deep, trim it deep so much that you get the whole surface appearing. Okay, so that is one of the causes of these curved sections. It can also be as a result of the dowel blade. Okay, when you have a dowel blade or the blade is curved. Okay, if the blade too is curved, you can have that due to the clumping. If you clump the tissue too much, the blade too much, it also produces curved nature, and then it produces curved this thing. And then if you have excess paraffin, so it also comes back to the orientation. Okay, during the embedding, if you don't embed well and then you don't press with the forceps for the whole surface to be attached to the bottom of the embedding mold, and then there is the surface is not flat, then wax enters in there to make it flat. And so if you don't trim it so much that the whole surface is produced, then you have wax in between there. You have excess wax filling up the space, and that can cause curved sections. Okay, or when you have inconsistency between the wax and then the tissue, you can also have this curved tissue. Okay, the curved sections. So how do you solve this problem? As I mentioned, you have to trim. You have to trim until you get the whole flat surface of the tissue if the tissue is curved. Okay, or if the blade is down, you have to change it, or the blade is not correct, you have to change it, and you have to trim. You have to reorient. Sometimes you have to go back and do the embedding all over again. You reorient the tissue, and then you start the process again. And then you also have thin and thick sections. So you have the same sections. Part of the section is thick, part of the section is thin. Okay, this can be a result of inconsistency between the tissue and then the paraffin wax. If the tissue is softer or it is harder than the paraffin wax, if each of them is the other way, if either the tissue is soft and the paraffin wax is hard, or the paraffin one is hard and the tissue is soft, can produce thick and thin sections. Okay. So in that case, you have to what? Put the wax or the block on ice so that the ice will create the consistency between it, will cause them to be hard, and then both of them will be hard at the same time. Okay. And then the clearance angle, as I mentioned to you, if the clearance angle is altered, it's not correctly set as a result of clamping the tissue the blade too much, okay, it can cause what? A problem. If it is, then you have to set the clearance angle well. Either you increase it or you decrease it, depends on. And then if you have the mechanism by which the microtome, the movement of the microtome, either the knife holder or the block holder moves. So if you don't clamp it well for it to be stable, and then it just is like jacking. So if it ejects like that, then you are going to get thin and thick sections. So as it ejects, it produces a thinner sections, and then it goes back to produce thick sections. So you get thin and thick. This one is vertical. It's difficult to. I hope you are, at least you are understanding what I'm trying to say. Okay. And then if the, as I mentioned already, if the blade holder or the block holder is not firmly tightened in their positions, they can also produce thin and thick sections. So you need to tighten it. Okay. You have to make sure that you lubricate the microtomes, calibrate, and check that everything is in place. Okay. Then you have factors. The factors are also called thin and thick, as I mentioned to you. Then you have scores, which is creating what cracks in the tissue. Okay, so you have chatters. So that can also be as a result of calcified areas or hard areas in the tissue, over dehydration of the tissue causing what? Hardness of the tissue, dull knives, excess, you have too much clearance angle, the block holder or the tissue blade holder is not firmly tightened in their places. Okay, so you can do that. You can correct that by tightening, by reducing the clearance angle, by softening the tissue if it is as a result of calcified area, or hardness as a result of over dehydration or over clearing, or too much temperature that's causing it to shrink and to become too hard. So in that case, what do? You rehydrate, or do surface decalcification, or you can go and re-embed back fresh paraffin. Okay, or you replace blunt knives. And then you also have splitting of sections. So you especially when the knife edge is, there are nicks at the edges of the knife. So especially if you have just cut a hard tissue, because of the sharpness of the knife, it means that the knife edge is very sharp. And so a little hardness causes indentation in the knife edge. And so if you have just cut a hard tissue, there's a tendency that you cause nicks, will cause this indentation in the knife edge. And so when you use it to cut subsequent sections, it will create lines in between. It will create these cracks, these lines in between the section. That is the splitting of section, or the caution. Okay, so you have hard tissue, hard particles in the tissue, or maybe if you have particles in the wax, so you can have stones or okay, small particles in the wax, and then when you use it, then it creates that cracks or splitting the section. So one thing to consider is you do surface decalcification to be sure that it is not calcium. If you do surface decalcification, you have changed your knife, you are using new knife, and it's still producing the splitting in the section or the cracks in the section, then it is possible that there are debris in the wax. So there are some particles, hard particles in the wax, and so you have to go and re-embed by filtering the wax that you are using. So you filter it before you use it to remove any debris, either dust particles or maybe wooden particle, any particle that is hard that can cause that. And then, as I mentioned to you, it is ideal that the section comes in ribbon. So they come following each other, one at a time. They just attach to one edge, okay? They attach to one another. Sometimes it is difficult to get ribbons as because of a problem with the block. So if you have wax that is so hard, okay, if the wax is too hard, it doesn't form ribbons, okay? If it's too hard, it doesn't form ribbons, okay? And then if there is debris on the edge, the knife edge, if there is debris at the edge of the blade or on the knife, it also prevents the ribbons from forming. And then if the clearance angle is incorrect, you can also have that problem. So you adjust your clearance angle, you clean the surface of the blade with xylene, especially if it is as a result of pieces of wax on the surface of the knife, you clean it. So ideally, before you cut any section, like after the first section, if you cut them, you have to clean the surface of the blade. And you have to do it cautiously, because if you are not careful, you cut off your finger because of the sharpness of the knife. So you clean it nicely to remove all the pieces of wax that have gotten attached during the previous section, so that don't create fault with any subsequent ones. Okay. And then sometimes if it's as a result of the wax being too hard, then you have to re-embed by using wax that are not too hard. Okay, so you use wax with wax. Okay. And then sometimes you cut the sections and then they become attached to the block. So you cut, ideally, when you go 360 degrees, it should cut and then it should fall off the surface of the block. Okay. But sometimes you cut after the 360 degrees, then it gets attached to the block. Okay. It gets attached to the block. It doesn't come out. It doesn't fall on the surface of the knife holder as it's supposed to be. That can be as a result of what? Insufficient clearance angle. Okay. Debris on the knife edge, debris on the block. Okay. Or heat on the surface of the block. Okay. So there is what? Static electricity. So there is this friction that affects the block, it makes the wax on the surface of the block melt, and then so when you cut, instead of it falling off, it gets to attach because of the heat that is okay. So the heat that is supposed to create the ribbons, it doesn't create the ribbons, but rather gets the section attached to. It's very difficult to explain about it. Sorry, I had to receive a call. So let's go on. So we are still on the causes of faults associated with microtomy. Okay. So you can also have excessive compression of the section. So excessive compression can be as a result of a dull blade or paraffin being too soft. Okay, softer than the tissue. So what you do is you have to use a new blade, and then you have to cool the block so that the paraffin will be hardened from the ice. And then you can also have sections that disintegrate on the water bath. So as I mentioned to you, if there is poor impregnation. Poor impregnation means that you don't have the wax in between. The wax didn't fill the cavities in the tissue. So your impregnation or infiltration was poor. So it didn't fill up. So there is still cavities in there. So when you place it on the surface of the wax, there is nothing. There is no wax to hold it together. So it causes what? Disintegration. Okay. Or maybe because the temperature of the water bath is too much. It's too high that it melts off the wax. So it dissolves the wax, melts it, and takes it out. And then it creates the cavities again. And then it causes what? Fragmentation or the disintegration of the tissue on the surface of the water bath. So if there is poor impregnation, you have to embed the tissue. You have to go back to infiltration. So you dewax, and then you start from infiltration. Make sure that you have done the infiltration very well, and then you embed, and then you go in section again. Or if it is as a result of too much temperature, the temperature is too high, then you have to reduce the temperature and you'll be fine. Sometimes when you section, then the section rolls like folding, like you rolling a mat or rolling a paper. You see, you have a paper in roll. Sometimes when you section, it rolls like that. When it rolls is because the needle is not sharp enough. If the needle is not sharp enough, or the rake angle is too small. So the rake angle is the angle between the block and then the knife edge, the upper surface of the knife. So the upper facet of the knife. I mentioned to you that the clearance angle is the angle between the lower surface of the knife or blade to the block. Okay, so the rake angle is the angle between the block, the top part, so the top part of the block, and then the upper surface of the knife. Okay, usually the rake angle depends on the clearance angle. So if the clearance angle is big, it means that the rake angle will be small. If the rake angle is big, it means that the clearance angle will be small. Okay, so usually the clearance angle determines the rake angle. Okay, so if the rake angle is too small, it means that the clearance angle is big. So when it cuts, it rolls up. Okay, it rolls up like you have rolled a paper. Okay, and so you have to reduce the clearance angle. Okay, and then sometimes when the section is too thick, when you have too thick a section, it can also cause the rolling up of the section. So you have to reduce the thickness of the section and produce thinner sections. If the blade is too dull, as I mentioned earlier, you can do that. So you have to put in fresh or new blade. I think this is the last one. Let me see. Yep, that's the last one. So with this, we come to the end of tissue processing. So do you have any questions before we go to the classification? On board? Are people here, or you have just joined in and you are doing your own things? Please unmute your mics and respond so I will know that I still have people on board.
No, we are here.
I'm the only one on board.
You're not the only one on board. We are here.
You're the only one on board, eh? Okay. You, I've heard.
Doc, please, about clearing and what else? What are some of the undesirable preparations like falls with clearing, and then I think we have talked extensively about the this part about the sectioning, the undesirable.
Yeah.
How about the earlier processes like the clearing and other steps?
Yeah. So I mentioned to you that clearing helps to remove materials that are soluble in the clearing agent, and it creates a transparent or translucent in the tissue. Okay.
Yeah.
So if clearing is not done completely, you can have the tissue being too soft because you have these dissolvable materials in there, and it will make the tissue too soft. Okay. If there is excessive, somebody's mic is on. If there is excessive clearing too, it removes excess, and so it makes the tissue very hard.
Yeah.
So in that case, that was what I was talking to you, that you leave the tissue on the surface of the ice tray for it to soak a bit of the water, so that it will soften it up. And then you can.
Please hold on.
Okay.
Ebenezer Dochi, please mute your mic. Ebenezer Dochi, please mute your mic.
Hey, is that Mr. Omari?
Yes, please.
Hey, I have big men on board. Great. All right. Please, the person who asked the question, are you okay?
Yes, ma'am. I'm okay.
So if you are processing and you don't, that is why you have to optimize. So processing is not just like you have gone, the schedule that you see has been optimized. Okay, all the schedules that I shown to you, it has gone through trials, and it has been noticed that at this time frame, it is ideal for this particular type of specimen. Okay, so you don't just start, if you are setting up a new pathology lab where you are going to do the processing, you also have to do some of these optimization to know that, oh, when you extend, these are some of the things that when you go for practicals, when you're in school and you go for practicals, I expect that you overdo some of the things because you are trying. You overdo some of the things, you underdo some of the things, and see the outcome of the section that you produce, and then you tend to understand. But students go for practicals and they are there. Sometimes they go there and they are just playing with their phones and chatting, and meanwhile they are tissue there. Some people may not have access to tissue because you are not exposed to pathology samples or something. But these are some of the things you should try your hands on. So for us, we have butchers around. So those who cannot get human tissue, you have butchers around. You go to the butcher shop, you buy any tissue at all, any meat, liver, kidney, whatever, even the normal meat, you buy fatty parts, then you come and try your hands on some of these things, and then you appreciate it more. Students don't do that. It is only what you tell them in the class. That is all. They don't, even what you tell them, they don't want to experiment to see whether what you are saying is the truth or not. Go and do improper dehydration from this thing, from the formalin. Don't go into alcohol, or just go straight to absolute alcohol and then go to clearing and see what will happen to the tissue. This is what you do at practicals. Okay, but I don't know. You leave them, you are not there, and you expect them to do certain things, and they will not. You even give them a schedule, do this, do that. They will go to the lab and they don't do it. And at the end of the day, a question is put before you, and then you are found wanting because you didn't do it yourself. Some people will hide behind others. Others will be doing it and they will be hiding because they are all in the same group, and they will think that they are doing somebody. You are doing yourself. It comes to the questions, and because you haven't done it, it's difficult for you to appreciate some of these things, and then you find yourself wanting in the lecture hall. So please, next time if you have the opportunity to go back to school, these are some of the things you have to do. Okay, so that you find out yourself what is happening. If you don't do it this way, what will happen? If you do it this way, what will happen? Okay, if you don't clear the tissue, what will happen? If you clear, what will happen? If you overclear, what will happen? If you underclear, what will happen? If you don't infiltrate, what will happen? Okay. So these are some of the things. Okay. Please, are you clear? The person who asked the question.
Yes, Doc, I'm okay.
Okay, thank you. So we are going to continue with decalcification. People had issues with decalcification. So just by its name, calcification means what? Accumulation of calcium. Okay. So decalcification means what? Removal of calcium. So there are two ways by which calcium can be accumulated in the tissue. So if you remember, those of you who did degree, DMLS or normal 4 years degree, you did general pathology, where you talked about pathologic decalcification. So there are two main ways by which the body accumulates calcium in the tissue. So it can be by dystrophic decalcification, where you have normal levels of calcium, but because of a pathology, there is a accumulation of the calcium in the tissue. And then you can also have metastatic calcification. That's as a result of high calcium level in the body. Okay, so you can have normal calcium level in your body, but you can still have calcium accumulation. And then you can also have high level of calcium in the body and have what? Calcification. Okay. So usually when we are
Madam,
talking
please,
about
what is the second type?
metastatic.
Megastatic. Okay. Thank you.
Metastatic and
Yes.
dystrophic.
Yes. Thank you.
All right. There is a chat. Let me see whether it concerns me. Okay. Am I sharing the slide on decalcification? Please, can you see the slides on decalcification?
No, please.
Oh, please.
No.
You can't see it. Yeah.
It's
You
the
can't
old
see.
one.
Oh, okay. Then let me stop the first one. Maybe because I didn't stop the first. Okay. Are you seeing it now?
Doc, we are seeing it.
Okay. So the first part that I mentioned is not part of the slide. I'm just explaining to you how calcification occurs in the body. Okay. So you can have calcium, you know, the body, the bones in the body are calcified. If you don't have calcium in your body, then it means that you cannot walk, because the framework of your body, the support, the anchorage of your body is the bones that you have. And so if your bones are not calcified, then I wonder how you are going to walk. Okay. Or how you are going to be stable, you are going to be firm. Okay. Move your body and all that. Even though you also have nerve control that helps, motor control that helps in the movement, but you need your calcium to keep you firm and make you able to stand, sit, or squat, or do whatever. So if, let's say, if you are studying calcification, if somebody has a tissue is brought to you which is calcified, if it is not a normal bone tissue, maybe somebody has osteosarcoma, or they suspect that somebody has osteosarcoma, or one of these bone related tumors. Okay, there are several of them. And so they will go and cut the part of the bone that after the scan, CT or X-ray or normal ultrasound scan, you're able to detect that, oh, this part of your bone has a tumor in it. Okay, a tumor growing in it. Then they will go and cut that part and then bring it to the pathology lab. Okay. Sometimes it's not a bony tissue. It is not natural bony tissue. Okay, it is a soft tissue like the skin, the liver, the spleen, the heart, any part of the body can be calcified. Okay, That is where we are talking about what dystrophic calcification and the metastatic calcification as a result of a pathology, as a result of a disease that is causing the part of the body that is not supposed to be calcified to be calcified. Okay. So when a tissue is brought and it is obvious that it is calcified, then you have to do what? Decalcification. If it is not obvious that it is calcified, and then you process, and then after processing during sectioning you realize that there is some fragment or pieces of calcium in the tissue, then you do what? Surface decalcification. That one we have spoken a lot about it, so I won't go into this. So usually when a sample is brought to the lab and it is calcified, it is allowed to fix. Okay, fixation is done. We make sure that fixation is complete. There is thorough fixation. And then you decalcify before you go ahead with the processing. So you don't start with the processing, go through dehydration and all those things before you come and decalcify. It is only surface decalcification where you go through the process before. But for actual decalcification, where it is obvious that the tissue is calcified, you do decalcification before the sample is processed, before you go through dehydration and other things. I hope that is very clear. I hope that is very clear.
Yes, ma'am.
Okay, go on. Okay, so great. So there are several ways of decalcifying the tissue. So the first thing is that when you get the decalcified tissue, depends on the size of the tissue. The smaller the tissue, the better or the faster the decalcification process. So usually when the sample comes and it is a bit huge, it is bigger than let's say 10 millimeters in thickness, then you have to cut it to about 5 to 10 millimeters in thickness, so that it can faster. Okay. So there are also you can use chemical means. Okay, there are two main ways of decalcifying the tissue. You have the chemical decalcification and then the chelating method. Okay, using chemical agents like acids. So you can use weak acids or a low percentage of strong acid like HCl. Can use very low percentage of HCl like 1 to 2% of HCl to decalcification. Otherwise, you use formic acid. Formic acid is a weak acid, or you use other weak acid. We'll go into details about the different chemicals that you can use for decalcification. And then you can also use chelating agents. So chelating agents, one of them is an EDTA. You know, in our normal blood, maybe you are going to do FBC, put it in EDTA. Why do you put it in EDTA? You want to prevent what? Clotting. And one of the factors that are involved in clotting, one of the components that enhances clotting is calcium. And so you want to remove calcium from the blood so that it doesn't aid in the clotting. Okay. So the EDTA is a chelating agent. It removes calcium, it binds the calcium ions and prevents it from binding to any other thing or activating the cascade, the clotting cascade. Okay, very good. So as I mentioned to you, the type of decalcification agent that you use, or the method that you use, whether it's chemical or chelating, and even the chemical, as I mentioned to you, there are weak acids and there are strong acids and other things. So it depends, or there are some factors that influences which method to use and which chemical to use. Okay, one of them is the intensity of the calcification. Okay, the degree of calcification or the density of the calcification. Okay, and then the investigations that are going to be done on the tissue. What you are going to use the tissue, how thick are you going to cut the sections? What exactly do you want to study the tissue with the calcium in it or with no calcium in it? All those things have to be put into consideration. And then also the staining technique that you are going to employ on the section, okay, on the tissue. What staining are you going to do? What subsequent, apart from the H&E, what other things are you going to do? Will the chemical or will the method affect the subsequent processes or methods that you are going to use on the tissue? All these things have to be put in place before you you perform decalcification. Okay. So usually when a calcified tissue is brought to the lab, it has to come with a radiograph. So you take the X-rays, or if it's X-ray they use to determine or scan, you have to get the imaging results, okay, of the body, the part of the tissue that was taken, so that you can be able to assess the extent of calcification. You know, when they take this imaging technique, the whiter the film, like the image, the more calcified it is. The intensity of the whiteness tells you how calcified it is, and then the darkness, the darkened part tells you that there is no calcium in the tissue, and so you want to see the intensity. So you look at the X-ray, and then it gives you the intensity, and then it also influences which method to use and other things. Great. Okay, so I've mentioned the different metastatic and dystrophic calcification. Okay. So what do you do decalcification? What are you supposed to do during decalcification, or what are you expecting from decalcification? So one of them is to what? Remove calcium salts from the tissue. Okay, to remove completely. And then one of them is also is that even though you are trying to remove the calcium from the tissue, you shouldn't cause distortion to the cells. Okay, because you are going to study cells in the calcified tissue. Okay, so in as much as you are trying to remove the calcium, it shouldn't have any effect on the cells. So it shouldn't affect the morphology of the cell. It shouldn't cause any distortion to the cells. Okay, and it shouldn't also what? Interfere with subsequent processes that the tissue is going to go through, especially staining. Okay, good. So for you to ensure that or to achieve a successful decalcification, you have to make sure that the assessment is done. So that's why I'm saying you have to add what? Radiographs, okay, to be sure that, oh, the tissue is truly calcified and all that. And there should what? Complete fixation. The tissue should be fixed before, okay. And I also mentioned to you that if the tissue is too thick, it affects the decalcification, okay. So the tissue has to be what? Cut into thin slices so that the decalcification can be hastened, it can be fast, and then it can be complete, okay. And then the choice of the decalcifier, what you are going to use for the decalcification, will also tell you whether your decalcification will be successful or not, okay. So, and then the duration, how long is going to spend, okay, will also be influenced by the density of the calcium in the tissue, okay. And then the volume of the reagent, the decalcifier that you are going to use. It's not that you are going to just immerse it in any volume at all. Just like you use the formalin, 10 to 20% the volume of the tissue, the same thing you have to use for the decalcifier, so that everything will be immersed, all the tissue will be immersed, and then the surface of the tissue will be exposed to the decalcifier that will help to remove the calcium from it. And also you have to make sure that you determine whether the calcification is complete or not. So you call it endpoint of decalcification, okay. There are also methods that you can use to check that. When we get there, we'll discuss that one. So you should be able to determine that the decalcification is complete. You don't keep the sample in the decalcifier. Remember, they are acids, okay. Most of them are acids, and you know how these acid can cause damage and all that. So you have to be intermittently checking whether the decalcification is complete or not, because you cannot tell if the tissue is in the decalcifier. You can't tell whether it has fully decalcified or not. So there are ways by which you can check whether the tissue is decalcified or they are not decalcified. And also you have to, when you decalcify the tissue, you have to know the schedule by which you process the tissue in. You have specific schedule for decalcified tissue. So now let's look at some of the methods. So I mentioned to you there are chemical method and chelating method. So with the chemical method, you have acid calcification, and one of the acids that is used is nitric acid, okay, aqueous nitric acid. So you use 5% aqueous nitric acid as your decalcifier. What does it do? It causes what? Neutralization. It combines with the calcium and then removes the calcium. Okay, so and it also helps in preventing swelling of the cells. Very good. So you also have nitric acid formaldehyde. So you have nitric acid in addition to what? Formalin. Okay, so you have a bit of formalin and then a bit of nitric acid, combination of that for decalcification. Why do you use the combination? So in each of the cases, there are advantages and disadvantages. So why do you use it? For rapid action, okay, and for good staining, because you still have formalin in there that will still complete the fixation if it is not properly fixed, okay. And then one thing also that we have to notice that when after decalcification, especially with the acids, we have to wash completely, because the acid can also hinder subsequent staining. So you have to make sure that the sample is washed completely. Okay, and then you have formic acid. So routinely, most places they use formic acid because formic acid is a weak acid, but it takes it time to decalcify. So decalcification is more gradual, but it's effective. Okay, it is effective. It doesn't cause tissue damage as the other acids will do. So when most labs use formic acid, okay, 5% formic acid for decalcification. And then you have tricloacetic acid. That one is used for tiny biopsies. So when you have, let's say, trypan biopsies is biopsy that is taken from the bone marrow. Okay, so if you have trypan biopsies where usually these ones are taken with needles, so very small fragments of tissue. You don't want to cause damage to the tissue. You want it to decalcify slowly so that it doesn't cause distortion to the cells in the tissue. So you use tricloacetic. Great. And then you have ion exchange method. So ion exchange, you use ammonium salt to take the calcium. So you know there is ion exchange. So there is negative anion cation interaction, and that allows calcium to be. So there's exchange. One replaces the other, and then the calcium is removed, and then ammonium ion is inserted. So when calcium is removed, that it's removing the calcium from the tissue. It is faster. It's a faster technique. So you don't use it for delicate tissue. You don't use it for fine biopsies. You don't use it for very small biopsies. Okay. And though it has advantages, and then you also have electrolytic method where you use the just like protein electrophoresis or sickle cell sickling electrophoresis. So it's the same method. So you have the cathode and the anode, and there is a movement of ions. They move towards the cathode because it's what the calcium is a positive, so they will move to the negative pole, just like electrophoresis. The same technique that is used. That's the electrolyte. And then you have the chelating. So the chelating example is the EDTA, as I've mentioned to you already. So the EDTA also helps to remove calcium. Usually EDTA is very weak. It takes a long time for EDTA to chelate calcium. So you use it for not very dense tissues. So fragile tissues like bone marrows and those tissues that are fragile. You use it. So now let's look at some factors that affect the rate at which decalcification occurs. So concentration of the acid is or the chemical is very important. Okay, the concentration. If you have higher concentration, it will cause distortion to the tissue. If you have too low too, it will not cause the removal of the calcium very well. And so you have to have optimum percentages to be able to decalcify the tissue very well. Temperature. If you have a bit higher temperature, you have a better decalcifying, because then it will enhance the penetration of the tissue by the decalcifiers. Okay, and then also the density of the bone, very, very important. So you don't percentage the low concentration for high density tissue, high density bone tissue. Okay, and then the thickness of the tissue, very important. Agitation enhances penetration, increases the rate at which the tissue fills in or enter the calcifier enters the tissue, and so it aids in faster digestion. So after you have introduced all your decalcifier, you have put the tissue in the decalcifier. I told you that you need to make sure that you check that the decalcification is done at all. Is it the tissue decalcifying? Is the calcium being removed or it is not? If it is being removed, has it been removed completely or there's still some in there? Okay, so you need to check the end point of decalcification. Very, very important. How do you do that? There are three main ways of checking the end point of decalcification. One of them is use of X-rays. So as I mentioned to you, X-rays takes what? Bone, takes calcium deposition in the body. If there is calcium deposition in the body, it's shown as white. If there is no calcium, it's dark, opaque, black. Okay. So if you want to check whether the tissue is decalcified, you take the tissue and you take X-ray of the tissue. If there is calcium in the tissue, you see the white patches in the image. If there are no calcium, you also see that that is the most accurate way, but it is not easy. That you need calcium, you need the X-ray to take pictures of people who have fractures and other things, other pathologies associated with the bone, and then you go and take tissue and you take it. I remember when I started working in the pathology, that they had an X-ray to check the endpoint of decalcification at the mortuary, but it got broken down, the spot, and we haven't repaired it again. So that method is not used. So the lab that has their own X-rays that is the best method to use. That is the best method to use, because if there is calcium, it will show. It will show that there is calcium. If there is nothing, it's black, then you are free. You know that there is calcium. It's very efficient and very accurate. And then you also have the chemical method. Chemical method is also good. So you use precipitation method. So you take I'll talk about it as we go on. The procedure out. So what you do is you take some of the decalcifying solution and then you expose it to some chemicals, and then if there is calcium in the solution, it will precipitate, and then you see the precipitates that tells you that there is calcium. So if there is precipitation, it means that there is calcium, so the tissue is not properly decalcified. If there is no precipitation, then there is no calcium in the tissue, and then it means that the tissue is completely decalcified. So one thing that you have to note about decalcification is that it is not one time point decalcification. So you don't put the sample in the decalcifier and then you think that is the end. No, you have to be changing the solution. Okay, the chemical the solution can become saturated with the calcium and it will not be effective again. So within time, maybe every 2 days or every 3 days, it can be a policy in the lab that you change. So you change frequently the decalcifying solution so that more calcium can be removed from the tissue. And the more you change, the faster the rate of decalcification. Very important. And then you also have a physical method. So the physical method is not accurate. It's the worst of all the method of determining endpoint of decalcification, because then you have to probe, use your fingers to check whether there's hardness. You might not feel minute hardness in the tissue. That is why sometimes you have to do surface decalcification. If all calcium can be felt or can be seen, then there is no need for surface. But because some of them cannot be seen or cannot be felt with the fingers, that is why they had to do surface decalcification. So it's not an ideal method. But if you don't have the above, and that is the only thing you can do. So you probe it. Use your fingers to touch the tissue to feel whether there is any hardness anywhere, or you can use needles. You can use needles to punch into the tissue. So So as you are using the needles, you are punching, and then the needles are also causing distortion. So in as much as you may miss the calcified foci, the foci of calcium in the tissue, you can also cause distortion to the tissue. Okay. So now let's see them one after the other. So for the chemical method, which is what is the, apart from the X-ray, that is the other method that is frequently used. Okay. So you use equal volumes of ammonium hydroxide and ammonium oxalate, and then you take a bit of the volume of the chelating agent, the calcifier, the calcifying solution. You add it to it, and if it precipitates, then there is calcium. If it doesn't precipitate, then there is calcium. There is no calcium in it, and then you go ahead. So anytime you are going to change the calcifying solution, you check the endpoint of the calcification so that you don't over decalcify and cause distortion. So as I mentioned, can be every 2 days or 3 days, depends on the intensity or the density of the calcium. It can be 1 week or 2 weeks, depends on the density of the calcium. In the physical method, I've also mentioned to you that you can use your fingers, you can use pins, you can use razor blades, you can use scalpel blades to cut. And when you do that, you are causing the distortion, and you can miss. If you are cutting and where you are cutting doesn't contain calcium, or the calcium is so small that the knife edge cannot feel it, then it means that you will miss it out. So it's not the best. So let's look at some of the points to consider for the calcification. So as I mentioned, before calcification is done, you have to make sure that there is complete fixation. The tissue is completely fixed, okay? And then you also have to don't over decalcify it. So you have to intermittently check the endpoint of decalcification before you change the solution. And then you wash completely when you are using the acid decalcifiers, okay? You wash completely. And depending on the intensity of the intensity, the size of the tissue, you choose the appropriate decalcifier for your decalcification. Okay. And then we also consider the other techniques that you are going to employ on the tissue, using the tissue, and then you know which of the methods will be, or which of the solutions will be ideal for decalcification. Okay. So I've mentioned the factors that affect decalcification, which is very, very important. So the size of the specimen, the concentration of the solution, the time, very important. That's why you have to be checking the endpoint of decalcification frequently so that you don't over decalcify and cause some distortion to the tissue. And then the volume of the solution, very, very important. And as I've mentioned to you already, if the tissue is thick, then you have to cut it into smaller sizes, about 3 to 5 millimeters in thickness, to enhance what complete of the. Any questions? Any questions? Any sense? We have come to the end of the classification. Any sense?
No, please.
Okay, so we'll end here. We'll end here and continue tomorrow, God willing, at 4. Is it 4? Eh? What is? No, is it 4? Yeah. Then we'll continue tomorrow. Yes, 4 to 6. Tomorrow is 4 to 6.
Yes, 4 to 6.
Okay. So please, if you have any questions, there is any question you want to ask, please ask. If I know, we will go and find out. If I know, I will tell you. Okay. Then if you don't ask questions, means that I'm also not learning from you. Want to learn from me? You don't want me to learn. So ask questions so that if I don't know, then I know that, hey, there is something I don't know, so I have to go and, even though I've been reading most of the time, but I still need to learn more. Okay. So we will end here if you don't have any questions, and then continue, God willing, tomorrow. And then, so if we have time, okay, we might meet again, maybe Thursday, Friday, and then maybe our last meeting, I will try and get some MCQ questions, ask questions and expect answers. So those of you who have logged in and you are not here, we'll have questions and then you will provide the answers. And then we'll see whether you are really getting what we are learning. Okay. And then it will also help you with your answering of your questions. Or you can also ask questions. If maybe you have come across any question you are not as sure of, ask. And then let's see if we can be able to help. Okay. All right. So thank you very much. See you tomorrow, God willing.
Thank you too.
Thank you very much.
You're welcome. Bye.
Bye.
Okay, good night, Sissy.
Good night, Sister Mary.
Hey, Mr. Mari, you are here.
Yeah, I'm straight at the corner.
Okay.
I'm not leaving.